morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan, Hotu Mese. Welcome back to the day 2 of the Second International Conference on Health and Medicine 2025, hosted by Faculty of Medicine, Universitas Patimura.
We would like to extend our heartfelt gratitude to all participants, speakers, and supporters who have made this international forum a success. We're especially appreciative of the invaluable support from our sponsors, PT Maju Jaya Medik,
PT Alkesmas Nusantara Jaya,
BLUD UPT Klinik Mata Ambon Vlissingen,
PT Mega Medical Pharmaceutical,
Global Dispo Medica,
Interbat,
PT Simex Pharmaceutical Indonesia,
Bank Negara Indonesia. As we continue to delve deeper into our central theme, collaborative approaches to advancing health in archipelago, innovative and integrative solutions, we now proceed with the first agenda of this morning, Plenary Session 2, focusing on crucial aspect of healthcare accessibility in island community. This session is titled, Reaching Every Island, Expanding Healthcare Through Digital and Virtual Solutions. To guide these important discussions, it's our pleasure to welcome the session's moderator, Dr. Gigi Christiana Relen Titale, MIPH, PhD.
Dr. Gigi Christiana Relen Titale is a respected academic and currently serves as a lecturer at the Faculty of Medicine, Universitas Patimura. She earned her dental degree from Universitas Indonesia in 2003, pursued a master's in international public health at Sydney School of Public Health, and later completed her PhD in medicine from the same institution. With a strong background in clinical practice, research, and health education, Dr. Gigi Christie has contributed significantly to the advancement of medical knowledge and public health through her academic, research initiatives, and professional engagement. Dr. Gigi Christiana, the floor is yours.
Check, check. Okay. Thank you very much, Joanne and Dicky, for a very nice introduction. Good morning, ladies and gentlemen, all resource persons who are already coming here. Thank you again for coming to the second day of ICHM 2025. My name is Christiana Titale, and I am honored to serve as a moderator for this session. And the theme of this session is, can you please go to the theme? Yeah. Reaching Every Island, Expanding Healthcare Through Digital and Virtual Solutions. As we might already know, across the globe, and particularly in archipelagic regions like Indonesia, the challenge of achieving equitable healthcare access becomes even more complex in the face of geographic barriers. Remote islands, limited transportation, uneven distribution of healthcare professionals create persistent barriers to health equity. However, we are also living in the era of remarkable opportunity. Digital health, virtual technologies begun to transform these challenges into possibilities. Telemedicine consultation, AI-based diagnostic tools, mobile health applications, or even drone delivery of medicine. We are witnessing how innovations can bridge the distance between patients and quality healthcare. Today's sessions brings together leading experts who will share their insight, real-world experiences on how technology, digital and virtual solutions could improve access to healthcare worldwide. And we want to ensure, like what we have been talking since yesterday, that no island is left behind. So without further delay, ladies and gentlemen, to begin our session, it is my pleasure to introduce our first speaker, Dr. Kartik Adapa, who is joining us online. Dr. Kartik Adapa is the Regional Advisor for Digital Health at the World Health Organization, Southeast Asia Regional Office, or what we call WHO Sierra. With a strong background in medicine, public policy, and public health, he holds an MBBS, Master of Public Policy, Master of Public Health by honors, and a PhD in Health Informatics from the University of North Carolina at Chapel Hill. His doctoral research focused on designing and evaluating health IT tools in radiation oncology. Dr. Kartik Adapa has extensive experience in digital health policy, AI innovations, and health systems strengthening. Dr. Adapa work emphasized cross-sector collaboration from government to academia and industry. He also a member of several editorial boards and review panels for leading journals and conference in digital medicine, health informatics, and human factor. So ladies and gentlemen, please join me in welcoming Dr. Kartik Adapa from the World Health Organization, Sierra. Good morning, Dr. Adapa. Can you hear us clearly? Dr. Kartik, can you hear us? Right.
Good morning. Can you all hear me?
Good morning, Dr. Kartik. Thank you very much for joining us this morning. I know it's very early in Delhi, like 5:40 in the morning, Dr. Kartik.
Yes, it's an absolute pleasure to be here. I'm just confirming again, can you all hear me?
Thank you so much, Dr. Kartik. And I heard that you are actually on leave, but thank you for sparing your valuable time with us this morning. So ladies and gentlemen, without further ado, Dr. Kartik Adapa will be delivering a talk titled Scaling Telemedicine for Universal Health Coverage, or UHC, Lessons from Southeast Asia. Our speaker will delve into how telemedicine has been used across the region, not only as a response to access challenge, but as a strategic pathway toward achieving universal health coverage. And we really hope we all can learn from this regional experience. Dr. Kartik, we have allocated 20 minutes for this presentation, and it will be followed by question and answer session immediately. Thank you, Dr. Kartik. The screen is yours.
Thank you so much. Thank you. It's an absolute pleasure. And if it's okay, can you allow me to share my screen, please?
Yes, Dr. Kartik. Can you please proceed?
Yes. Perfect. Awesome. Thank you. Can you all see my screen? Can someone confirm that they can see my screen, please?
Yes, we can see your screen. Sorry, the microphone is not working. Okay, we can see your screen. Thank you.
Awesome. Thank you. Thank you, everyone. It's an absolute pleasure to be here this morning to deliver on the importance of how telemedicine is revolutionizing healthcare delivery in low and middle income countries, leveraging digital platforms to bridge geographical and socioeconomic gaps. Now, there is a lot of enthusiasm for telemedicine in LMICs, which essentially stems from its measurable impact by reducing travel costs, improving patient adherence, and optimize resource allocation. Now, what I will do is I'll start with firstly how telemedicine has been defined with the World Health Organization and the guidelines on the WHO are essentially on Consolidated Telemedicine Implementation Guide, which provides a robust framework for integrating digital solutions into health systems, emphasizing scalability and sustainability. Now, the guide essentially outlines key principles, including patient-centered care, interoperability of digital platforms, and adherence to data privacy standards. By standardizing protocols, it mitigates risks associated with fragmented healthcare delivery, ensuring that telemedicine interventions are both effective and equitable. Now, you do have access to this to the QR code, which can give you access to this resource. Now, the WHO guidelines.
Dr. Karthik, sorry, can you hear me?
Yes, please.
Yes,
Yes.
Dr. Karthik, do you mind stop sharing your screen and we can share it from our end? Because by sharing at our end, we can display your face actually on the screen. Is it possible?
Okay, let's do it.
Yes, thank you so much.
Let's do it.
IT, please. Can
Next
you
slide,
see the
please.
screen? Yes.
Yeah. Yeah. Perfect. Thank you.
Thank you.
So I was talking about how the WHO guidelines on digital interventions underscore telemedicine's role in enhancing accessibility to health facilities and human resources. Now, the client to provider telemedicine essentially addresses the shortages of qualified health workers by enabling remote consultations, ensuring that patients in underserved areas receive timely care. While the provider to provider telemedicine further strengthens health systems by facilitating expert consultations, reducing diagnostic errors, and optimizing resource use. Now, by addressing challenges like geographic isolation and insufficient health worker competence, these interventions enhance care quality and system efficiency. And the evidence from the WHO's 2022 report clearly highlights how telemedicine's transformative impact during crises like COVID-19. Next slide, please. What we want to essentially do, therefore, here is scaling telemedicine requires a strategic reference framework that aligns technology with health system goals as outlined in WHO's digital health strategies. By leveraging scalable platforms, countries can extend care to remote populations, addressing disparities in access and quality. Now, I will present a reference framework which emphasizes on interoperability, stakeholder consultation, and robust regulatory oversight to ensure sustainable scaling. And by integrating telemedicine to the national health policies, countries can optimize resource allocation, reduce cost, and enhance patient outcomes. Next slide, please. Now, there is the importance of telemedicine and why we need to scale telemedicine essentially as a pathway to achieving universal health coverage, essentially kind of demonstrates how telemedicine has been a game changer for universal health coverage, as evidenced by India's e-Sanjeevani program, which has facilitated over 200 million consultations in 2024. By eliminating the need for physical travel, it essentially saves patients an average of 21 kilometers per visit and $11 in cost, with greater savings for women. Further, the 24/7 availability of teleconsultations ensures that patients receive timely medical advice, reducing delays that exacerbate health conditions. By connecting patients with providers, regardless of location, telemedicine mitigates geographic barriers, a critical factor in low and middle income countries. Now, these outcomes align with WHO's vision of equitable healthcare delivery. Next slide, please. Now, what we've essentially done here is, in terms of quality of care, telemedicine enhances care quality through standardized protocols and digital decision support tools, ensuring consistent and evidence-based interventions. By providing access to specialists and enabling follow-up care, it bridges gap in local expertise as supported by Cochrane's 36 systematic reviews affirming telemedicine's efficacy. Now, this highlights the scientific foundation of telemedicine's quality improvement. Now, health system efficiency is bolstered by reducing unnecessary referrals and facility congestion. allowing resources to be allocated to critical cases. Real-time data collection supports public health planning, enabling proactive responses to emerging needs. Now, WHO's findings on telemedicine's role during COVID-19 underscore its capacity to maintain essential services under strain. Next slide, please. Now, telemedicine, specifically during the COVID-19 pandemic, has proved indispensable, particularly in LMICs where healthcare resources were stretched thin. By enabling remote consultations, it maintained continuity of care, reducing the risk of virus transmission in crowded facilities. Now, this showcases telemedicine's adaptability in crisis situations. In LMICs, telehealth mitigated the uneven distribution of healthcare workers, ensuring that remote communities access critical services. Now, WHO's analysis highlights how telemedicine supported essential care delivery from chronic disease management to mental health support during global lockdowns. These outcomes validate telemedicine's role in resilient health systems. Next slide, please. Now, in terms of evidence on what works, if we look broadly into the provider-to-provider telemedicine models, they enhance care delivery by connecting frontline healthcare workers with specialists, as seen in programs like Clinico Plus in Guinea and eSanjeevani healthcare worker in India. And these models essentially address gaps in expertise, enabling community health workers, nurses, and pharmacists to consult doctors for complex cases. Now, examples also include nurse-to-specialist consults for expert opinion and doctor-to-doctor discussion for second opinion, improving diagnostic accuracy. Now, programs like Telemed KG in Kyrgyzstan demonstrate how P2P models streamline referrals and enhance care quality. Now, the evidence here underscores their role in optimizing health systems resources and patient outcomes. But what we are also seeing, next slide, please. We're also seeing client-to-provider telemedicine models, which enable direct patient access to healthcare professionals, as demonstrated by initiatives like Panama Telemedicine Project and Sehat Kahani in Pakistan. From doctor to patient consultations to nurse-led triage, these models cater to diverse needs, including chronic and mental health. Now, this highlights their evidence-based impact on accessibility, and there have been a variety of specialized client-to-provider applications such as teleoncology at Tata Memorial Hospital, Mumbai, and teletherapy for mental health, which showcase telemedicine's versatility. Now, by facilitating initial consults, follow-ups, and remote monitoring, the client-to-provider models reduce barriers to care, particularly for underserved population. Next slide, please. Now, we would also like to talk a bit about the modes of care delivery in both the two models. In both the P2P and the client-to-provider models, they operate in both synchronous real-time or asynchronous modes, offering versatility in care delivery. The synchronous consultations via video or chat ensure immediate feedback, while asynchronous methods allow for detailed case reviews, improving diagnostic precision. Next slide, please. Now, telemedicine specialized applications like teledermatology and tele-ICU, telepathology, all of these leverage digital tools to deliver targeted care, as seen in programs like Cloud Physician and Scenes V-Dots for TB adherence. By enabling store and forward imaging and remote intensivist support, these applications address critical healthcare gaps. Now, there are also applications like teleradiology and telerehabilitation, which enhance diagnostic accuracy and patient recovery by connecting providers to specialists. The hospital-to-home models extend acute care to patients' residents, reducing facility strain. And the evidence from global implementations highlights their role in improving outcomes across diverse domains. Next slide, please. Now, telemedicine typically thrives in diverse settings, from school and workplace kiosks to prison health services, as exemplified by programs like the Addis Clinic from cross-border care. Now, these environments address unique access challenges, ensuring care delivery in constrained or remote contexts. Now, emergency care models like paramedic to doctor consultations enhance pre-hospital outcomes. And so what I want to do is I want to talk a bit about implementations. Next slide, please. Now, scaling telemedicine requires a very defined approach, which is grounded in evidence from successful programs. Now, in terms of the lessons learned, what's going to be very important is that telemedicine typically excels in primary care, but what is going to be very important is in terms of an effective design which contributes to the program success. What we've essentially seen is that a very simple and a quick, easy tool to bring together diverse stakeholders is going to be extremely important in terms of an effective design for a program success. And there has been a lot of evidence on the importance of designing it very early and an effective design and how it contributes to program success. Next slide, please. Sorry, I'm just checking in. I think we're here on this slide on design, which I was trying to talk about. Okay, next slide. Yeah, thank you. Now, we've also talked about using a very, essentially on what are the key lessons that we can learn on implementing telemedicine at the primary care. One of the first lessons that we've essentially realized is that telemedicine provides comparable or superior outcomes and in comparison to traditional care. But it's also very important to understand that this evidence is essentially in primary care, mental health, radiology, and chronic disease management, primarily because it delivers outcomes comparable. Now, essentially from remote dermatology diagnosis to cardiology monitoring, it addresses diverse healthcare needs, and there is a scientifically validated scope for telemedicine applications across all these areas. Now, even in pediatrics, sorry, can you all hear me?
It's fine, Dr. Karthik. Please proceed. Thank you.
Thank you. In pediatrics, telemedicine typically supports consultations for minor illnesses, while in rehabilitation, it enables remote exercise guidance. Now, these applications reduce barriers and enhance patient engagement, supported by evidence from systematic reviews. Now, by targeting specific domains, telemedicine maximizes health system efficiency and care quality. Next slide, please. Now, what we've essentially, next slide, please. If you could move forward. Yes, thank you. Now, what we've essentially seen is that we've designed this telemedicine program design canvas, which identifies 14 elements, including target population, channel, drugs diagnostics, which are critical for program success. For instance, women in LMICs typically face barriers like limited phone ownership, making health worker facilitated channels more effective. Now, evidence suggests that integrating telemedicine into a broader care ecosystem ensures continuity and accessibility, particularly for rural and urban populations. Now, the canvas that you see here on the screen, which is available via Oxford Open Digital Health, provides a roadmap for addressing these challenges. We've been using this canvas across many of our countries, and I will provide some examples going forward. Now, by prioritizing these elements, programs can achieve sustainable impact. Next slide, please. Now, telemedicine also essentially has to adapt to local contexts, and what is therefore going to be very important is to recognize that telemedicine is going to require a high upfront investment, and the move to be especially to acquire clients, to change provider behavior by adoption. Developing culturally appropriate and scientifically accurate content, especially that is one that is aligned with the beliefs and the values of the clients. Now, it is only when you make such high investment that there is going to be more adoption, and then there is going to be a lot of evidence on the return of investment. Now, for example, we have evidence that for every $0.24 that is invested in telemedicine for NCDs, there is a return on investment of up to $19 for health systems. Now, it also shows that telemedicine can improve gender equity because prior to telemedicine, 6 out of 10 women delayed their care or missed care, while with post telemedicine, 9 out of women got to care without any delay. So there's a lot of scientific evidence that underscores the value of an adaptive evidence-based approach in telemedicine scaling. Next slide, please. Now, for last mile populations, especially to the healthcare worker to doctor telemedicine models, they're highly effective, especially when they're driven by local health workers and word of mouth promotion as per implementation evidence. Now, these strategies enhance adoption by building trust and accessibility, particularly in rural settings. Now, repeat usage is influenced by consultation quality, single visit care, and cost effectiveness, as seen in programs like Clinico Plus. By prioritizing user-friendly interfaces and affordable services, programs can sustain patient engagement. Now, the evidence essentially scores the importance of a patient-centered design in a telemedicine success. Next slide, please. Now, effective regulation is certainly very pivotal for scaling telemedicine globally, and it essentially encompasses an authority oversight, provider eligibility, and data privacy standards as outlined by WHO's telemedicine implementation guide. Now, these elements ensure accountability and patient safety, which is also supported by evidence from the Asian Regulatory Network. Now, regulation should address patient consent, telemedicine technology standards, and reimbursement policies to foster trust and interoperability. Now, by establishing clear guidelines, countries can mitigate risks and enhance program sustainability, as seen in Sri Lanka's robust framework. Now, the evidence highlights regulation and its role in scaling telemedicine effectively. Next slide, please. Now, in the slide, you can actually see that there are about 23 countries in Asia, which is about 45% of them, including countries like Indonesia, India, Sri Lanka, which have either telemedicine laws or non-binding guidelines, which clearly reflects a growing commitment to digital health governance. Now, these frameworks address provider accountability, data security, and patient consent, ensuring safe and scalable interventions. Now, countries like Japan and Singapore have pioneered interoperable standards, enhancing care across borders. Now, the evidence from these frameworks demonstrates their role in building trust and facilitating telemedicine adoption. Now, by aligning with the WHO guidelines, Asian countries are typically strengthening their health system resilience. Next slide, please. Now, I also want to kind of get into some case studies across different countries in Southeast Asia. And let me start with how Sri Lanka developed a robust telemedicine guideline through inclusive stakeholder engagements, which were led by the Ministry of Health's Health Information Unit. In providers, the process ensured comprehensive input as per WHO's best practices. Physical and online meetings were facilitated, basically consensus on key elements like provider eligibility and data privacy, aligning with the global standards. Now, the resulting guideline enhances full implementation. Sri Lanka's approach is a blueprint for LMIC countries wanting to scale telemedicine. Next slide, please. Further, Sri Lanka's telemedicine regulations essentially emerge from a foundation of robust digital health standards, including the national policy on health information and the information in the security guidelines. These standards ensure interoperability and data security, which are critical for scalable telemedicine. The Ministry of Health strategic vision outlined in its 2016 to 25 National Health Policy integrates telemedicine to the broader digital health goals. Now, by prioritizing standardized protocols, Sri Lanka enhances care quality and system efficiency, which is supported by evidence from global best practices. Now, this could essentially be an approach for a lot of Southeast Asian countries. Next slide, please. Now, what is also very important to highlight here is that Sri Lanka's telemedicine law and its guidelines are embedded within a comprehensive digital health ecosystem, including the National Digital Health Blueprint and guidelines launched under the 2016 to 25 National Health Policy. You can see that this framework ensures interoperability, data privacy, and care continuity. The National Digital Health Blueprint architecture facilitates seamless integration of telemedicine into the health systems, optimizing resource use and patient outcomes. Now, therefore, this evidence from Sri Lanka's implementation highlights its role in scaling care delivery, particularly in rural areas. Now, this approach aligns with global best practices for digital health governance. Next slide, please. Now, if we move to Indonesia, which is again has telemedicine regulations which are very aligned with its digital health strategic plan, they clearly establish guidelines for provider accountability and data security. Now, by prioritizing interoperability, it ensures scalable and equitable care delivery. And it's essentially a very scientific model here. Now, there is a stakeholder collaboration involving the Ministry of Health and private sector providers, which has essentially driven the development of these robust guidelines, which enhances trust and adoption. So evidence from Indonesia's inspired programs highlights the impact of regulation on care accessibility. And this essentially is an approach for a lot of LMIC countries scaling telemedicine. Next slide, please. So what I also want to do is provide some few case studies on successful telemedicine programs in Southeast Asia and beyond. Next slide. I'll start first with this example from India's eSanjeevani program, which typically exemplifies the power of a provider to doctor and a client to a provider model, delivering close to about 200 million consultations. And you can see that essentially the telemedicine consultations have grown over the years. And these are essentially by connecting nurses to doctors for triaging and patients with providers for direct care, which enhances its accessibility and it typically highlights the scientific impact of eSanjeevani in providing equitable care and providing quality. Next slide, please. Now, eSanjeevani essentially has two variants. One is a provider-to-provider consultation, as I talked about that a little earlier, where it connects the nurses at the front line to doctors in the primary healthcare or CHCs or hospitals in the primary and tertiary care. It also has another variant, which is essentially the provider-to-patient teleconsultation, where essentially clients can directly connect with physicians, providers via mobile app. And studies show that eSanjeevani's outcomes include about $3.4 billion in saving, and which typically validates its role in universal healthcare. And this program is essentially a global benchmark for telemedicine scaling. Next slide, please. Now, what is also very important is in this slide, you can see that there's been a huge focus on thinking about workflows. So whether it is the eSanjeevani OPD version or the eSanjeevani, which is typically from the client to the provider, there has been a thinking on how do we ensure that the entire workflows for the patients and the providers are streamlined. And this is essentially an example of the streamlined workflows and the need to ensure that the experience both for the providers and the patients is seamless. Next slide, please. Now, essentially, what we're trying to say is that the impact of eSanjeevani is profound because it's essentially ensuring easy access. It is typically contactless and it's free of cost. So for patients, there has been a benefit of about 21.5 kilometers of travel, and we're also able to save close to US dollars 10.88 US dollars, both in direct and indirect costs. And and studies suggest that there is a cumulative cost saving of about 3.54 billion US dollars. Now, this program's contactless, free of cost model ensures equitable care delivery, particularly for the underserved population, aligning very clearly with the universal healthcare goals. Now, the evidence underscores its role in reducing financial burdens and improving health outcomes, making it almost a good global model. And therefore, this is certainly a call for action for a lot of Southeast Asian countries. Next slide, please. Very recently, they've also, eSanjeevani also started using an AI-based differential diagnosis and also providing physicians and more specifically the community health workers on giving differential diagnosis in selecting appropriate specialties. Now, just based on a variety of both supervised and Gen AI models, they're able to assist doctors with differential diagnosis, and also based on chief complaints that the CHO, the community health worker, enters, it also gives them a differential output in terms of which specialty to choose, especially when they're not very clear. So there is also movement where we're thinking about integrating AI within telemedicine in the eSanjeevani program. Next slide, please. Now, let me walk you through the Clinic O Plus from Guinea, which essentially delivers nurse-to-doctor telemedicine for primary care, which is essentially, especially in rural areas, which has generated significant value as per program evaluations. Now, the program's cost effectiveness with every $1 invested yielded substantial returns, as you can see on the screen, which underscores its sustainability as evidenced by various impact assessments. By integrating local healthcare workers, Clinico Plus ensures community trust and adoption, which is critical for last mile populations. Next slide, please. Now, I also want to walk you through the Panama telemedicine project, which essentially serves over 60,000 patients across 12 health regions, which typically targets chronic diseases like diabetes and hypertension, as per 2024 data. Using scheduled phone consults and remote test reviews, it enhances accessibility and it's clearly supported by the WHO guidelines. Now, backed by the World Bank, JICA, and PAHO, the program leverages robust infrastructure to manage 20 patients daily per doctor, optimizing efficiency. Now, the evidence highlights its role in reducing travel and empowering patients and aligns clearly with the UHC goal. And Panama's approach could be interesting lessons for Southeast Asian countries. Next slide, please. Now, what also the evidence that is emerging from the telemedicine project at Panama essentially shows that it reduces travel time, missed work, empowers patients through self-monitoring, and then it also decongests health facilities by prioritizing care, enhancing system efficiency. Now, the program reaches remote and indigenous areas, ensuring equitable care delivery, as evidenced by the outreach data. Now, the plans to integrate primary healthcare with specialists via referrals could further enhance outcomes, and Panama's equity focus is certainly a model for Southeast Asian countries. Next slide, please. Now, let me walk you through some important findings that we have from the Ghana's telemedicine initiative, which typically operates a 24/7 nurse midwife run triage call center, which is currently serving 7 million people as per 2024 data. With escalation to doctors and referrals to tertiary care, it ensures timely interventions, and the call center staffing model with 8 nurses and an on-call physician optimizes efficiency as evidenced by operational metrics. Now, this is a very structured referral protocol which ensures seamless care transitions enhancing outcomes. Again, Ghana's approach could be a blueprint for scalable triage systems in low and middle income countries. Next slide, please. The Ghana's telemedicine training essentially follows a three-level approach, national, regional, and district, ensuring provider competence. Refresher trainings are provided every 6 months, and standardized toolkits enhance care quality, which is supported by evidence from program evaluations. There's a local emergency transport network integrating drivers and providers, ensuring timely referrals as evidenced by operational data. By fostering community collaboration, Ghana has enhanced care continuity, particularly for rural populations. And this integrated approach could essentially be a model for Southeast Asian countries. Next slide, please. Now, let me walk you through the last model, which is the telemedicine KG from Kyrgyzstan, which is essentially a provider-to-provider telemedicine for maternal and child health, which enhances care quality by addressing expertise gaps. It improves outcomes for high-risk pregnancies and pediatric cases. Now, the model facilitates real-time consultations and asynchronous reviews, ensuring timely interventions as evidenced by global case studies. Now, by integrating specialists, it reduces maternal and child mortality, which essentially aligns with SDG targets. Now, this could be a very critical approach for low and middle income countries with limited specialist access. Next slide, please. Now, essentially, in Kyrgyzstan, we've typically used a 4-phase model. We started first with a landscape assessment of the telemedicine projects in the country in 2019-20, followed by working closely with the Kyrgyzstan government to develop a country medicine telemedicine policy. And then we started telemedicine pilots in 3 provinces for childcare in collaboration with UNICEF. And then over the last year, we've expanded to maternal health and other use cases in additional provinces. So using this phased approach, we've been able to ensure that there has been a clear movement from landscape analysis, policy, and then piloting it and expanding it to the national level. Now, colleagues, thank you so much for your patience. Next slide, please. I know it's been a fairly lengthy presentation, but before I leave, I wanted to kind of also offer some resources. WHO CRO, in collaboration with IntelliHealth, has been organizing a webinar series with a goal to essentially think about telemedicine. We are hosting this to build capacity for telemedicine integration. And the goal is to address system challenges and equip stakeholders with practical insights, well supported by global best practices. Now, these telemedicines, we are offering them as a series. Next slide, please. It is a 13-month series. It typically spread every month. We have one series, one webinar every month around these very critical topics we've covered yesterday, essentially evaluating telemedicine interventions, what is the evidence and what are some evidence-based methodologies that could be used in evaluating telemedicine, and we are hoping some of you could join these webinars. So thank you so much. Next slide, please. This comes to the end. Thank you so much. This has been an absolute pleasure for me to join here. I hope through this approach on how telemedicine could be scaled, there are some very interesting lessons that are emerging from Southeast Asian countries, and there are also important lessons that we could learn from countries beyond that as well. Thank you so much for having me here today. Thank you.
Thank you so much, Dr. Kartik, for your insightful presentation. Thank you. And we are coming to the question and answer session. For those who have questions, please raise your hand. You can walk to the mic here, the microphone here at the front, and ask a question. Please, Dr. Maxwell.
Thank you very much, Dr. Kartik. I will ask you a question about, in your opinion and based on your presentation, the telemedicine program or system is better under hospital or under specific medicine department in university regulation, or maybe should under health ministry to provide the healthcare services, especially for archipelago island like us in Maluku province. Thank you very much.
Dr. Kartik, can you hear the question?
Yes, yes,
Oh,
thank you. Thank you
Thank
so
you.
much. That's an excellent question. Now, it's not an either or according to me. I think telemedicine works extremely well when we would want to use evidence, essentially both in terms of both a provider to provider. So it does not have to be essentially only run by the Ministry of Health. It could be in starting with some specialized services as well. Because essentially, you want to ensure that patients, so for me in telemedicine, the focus is patients, right? It has to be patient-centered approach. So the first goal has to be, how do we ensure that we can use telemedicine to provide more access? Now, whether it is access to special services or access to even primary care services. So the goal is, as long as you make it a patient-centered approach, as long as we understand the patient goals. Now, if patients in the area that we want to serve essentially need special services, yes, ensuring that the special services are emphasized is going to be critical. But if the goal is to ensure that we want to provide primary care services, then it has to be a patient to a provider connect. So I think it's going to be very important that we do first a situation analysis to understand what are the patient goals and then build telemedicine on top of that. So, and that's the reason why I identified this Kyrgyzstan model, where we did a deep-rooted situation analysis to understand what really are the patient engagement, patient goals, and then build the telemedicine to match the needs and priorities of the patients and ensuring that we have the infrastructure, the digital infrastructure and the physical infrastructure to match that.
Thank you, Dr. Kartik. Is that okay? Okay, thank you very much, Dr. Maxwell. Dr. Kartik, it's a very nice presentation. It's really good to see that, like, I am amazed myself, like 200 million consultations per year. How it can save enormous amount of money. And like Dr. Kartik already mentioned, it's a great investment is required to develop culturally appropriate and scientifically accurate content of the telemedicine, which is based on the patient needs and their culture and their beliefs. Maybe any more question from the floor? Dr. Ronnie first, please. Yes. Maybe Dr. Ronnie and then Ibu Melda. That's the last question for today's session, for Dr. Kartik's session, I mean.
Yeah, thank you very much, Doctor, for the opportunity. Based on the presentation, I think telemedicine is very depending on technology, right? But how about our country, especially Indonesia and Ambon? It's archipelago country and a lot of rural areas here. And then sometimes our signal or network here is lost and we cannot consult to our doctor or someone. So can you give us advice or tips to solve this problem? Thank you.
Thank you, Dr. Ronnie. Can you hear it, Dr. Kartik? Yeah, thank you. Yes, please.
It's a very valid point. And that's the reason why we talked about the importance of basic physical and data infrastructure, right? So essentially anything digital would need an infrastructure. It's almost like constructing a house, right? When you want to construct a house, the first thing that you would focus is the foundation. And then you would construct the roof, the brick, the walls, the roof and the superstructures. So telemedicine as a digital health application would need some foundations. And some of the foundations are the ones that you talked about, which is essentially on connectivity, which is essentially on ensuring that there is broadband, both on the broadband connection, essentially on the provider side and the patient side. Now, what is going to be important here, where telemedicine can certainly play a role, even when the connectivity is very less, where there are challenges in connectivity, the telemedicine application can be lightweight. So there are lightweight telemedicine applications that are coming in, which ensure that with broadband challenges that are there, we can still connect, patients and providers can be connected. And the other thing that we can typically do in areas where there is low connectivity is the importance of asynchronous reviews. So what is going to be important there is you could typically ensure that digital records, when the connection is slightly more available, you can upload those reports and then make them accessible to the provider and then take guidance and reviews from providers. So not just asynchronous, if synchronous is not possible, we can even consider asynchronous. We could also consider low weight telemedicine applications so that the application by itself is not very heavy and does not use a large amount of bandwidth to run these applications. So these are some ideas that I wanted to share.
Check. Thank you, Dr. Kartik. Dr. Ronnie, yeah. Maybe next, Ibu Melda. One more, Dr. Kartik, sorry, from Ibu Melda.
Thank you.
Thank you for the time given to me. Sir, I would like to ask you a question. As we know that India has a large population, do the current telemedicine access guidelines in India adequately cover or address P2P or D2P consultations, especially for rural communities who have limited access to the technology? Yeah. Or are regulatory updates needed to ensure effectively implementation? Yeah, I think that's all my question.
Yes, Dr.
Thank
Kartik,
you.
please.
Thank you. I could not completely hear the question. Did it talk about how is telemedicine being made accessible to rural areas in India? Is that the broad question?
Yes, Dr. Kartik.
So in India, essentially over the past decade or so, there has been a large amount of telemedicine penetration. So over the lakhs of rural areas that are available in India today in terms of telemedicine, in terms of internet penetration, there is about 86% of all the villages in India have at least a 3G or a 4G telemedicine connectivity. And then the smartphone penetration has also increased tremendously over the past decade or so. So one of the reasons why you see such large millions of telemedicine consultations, and to be fair, most of these telemedicine consultations that I shared are essentially from rural India. And this is primarily because of both the telemedicine as well as the smartphone penetration that we're seeing in India. And specifically during the COVID times, what we've seen is it is the underserved, marginalized communities and women who actually use telemedicine more than the urban population or men, for instance. So what we are able to learn essentially from telemedicine implementation is telemedicine essentially provides access and predominantly caters to marginalized and underprivileged population, provided the foundations that you need, which I talked about, connectivity and ensuring that there is an application that is lightweight, and there is also an opportunity for a patient to provide a connection. Once that facility is provided, what we've seen is telemedicine has been able to help also gender equity and also reduce the rural-urban gap in terms of providing access to care.
Thank you so much, Dr. Kartik. Okay, maybe Dr. Kartik and ladies and gentlemen, that's the wrap-up of the first half of this second plenary session. And please, we would like to thank you again, Dr. Kartik, for your time, for your valuable time early in the morning in India. And
Thank you.
We would like to present a token of appreciation that will be displayed on screen, Dr. Kartik, for you from all of us here in Ambon.
Thank you so much
Yes,
for having
Dr.
me
Kartik.
today.
Yes, thank
Thank
you
you
very
so much for
Dr.
having-
Kartik. And have a good leave too. Have
Thank
an
you,
enjoyable break time. Thank you, Dr. Kartik. Good morning.
Thank you. Thank you so much. Thank you. Thank you.
Okay, ladies and gentlemen, we are back again here offline in this room, and I welcome all the participants who are just coming. We hope you can have an enjoyable session with us here. And we are going to invite our second speaker, who will share a compelling case study from Australia. Our second speaker, let me introduce her, is Amanda Hunter, Master of Applied Management in Nursing. She is a registered nurse, dedicated virtual rural care clinical nurse consultant at Western New South Wales Local Health District in the Western Virtual Division, Australia. Since joining the service in 2012, Amanda has encompassed many positions, including nurse coordinator, critical care advisory service nurse manager, nurse navigator, and acting general manager. Extensive critical care nursing experience from 1995 to 2012, engaging in various leadership and education roles in regional healthcare settings. With extensive experience in critical care, leadership, service transformation, and innovative virtual models of care tailored for rural and remote communities, Amanda has carved a significant niche in the nursing profession in the Western New South Wales Local Health District. Key function in current CNC role includes clinical leadership, research, service planning and management, education and clinical service and consultancy. And by continuing to leverage her leadership skills and clinical expertise, Amanda Hunter remains at the forefront of healthcare innovation, striving to make a meaningful difference in the lives of rural and remote population. So ladies and gentlemen, please welcome Ms. Amanda Hunter. So Amanda, good morning again. How are you going?
I'm going well, thank you.
Oh, that's
Bit
nice.
nervous now.
Hope you had a good rest last night.
Yeah.
Okay, thank you very much once again for joining us here
Thank you.
in the morning. It's quite early actually. Okay, today Ms. Amanda Hunter will be delivering a talk titled Enhancing Healthcare Accessibility and Quality in Rural and Remote New South Wales, NSW, Australia since 2006, the Western Virtual Division. This presentation highlights the Western New South Wales Local Health District's innovative efforts to improve healthcare accessibility and quality across one of the largest and most geographically dispersed regions in New South Wales, Australia. The presentation emphasized the outcomes, challenges, lesson learned, and potential for adaptation in similar settings, particularly in other island or rural health systems, including in Ambon and in Indonesia. Amanda, you have 20 minutes? Okay, the floor is yours.
Good morning, everyone, and thank you for the invitation to share our experience in Western New South Wales. Firstly, I'd like to sincerely thank everyone for the warm welcome to your city and to your country. It's been a wonderful experience. I'd also like to pay my respects to the Indigenous people of both our communities, of where we work and where we live. It is a great honour for me to visit your city and hear about your communities and the innovations. Next slide, please. As you can see from the overlay of the maps of Indonesia and Australia, the geography of where we work is vast, whether it be by land or ocean. It disperses our population and it disperses our resources, and it's really hard to access care. Today, I'd like to share with you how we work in Western New South Wales. Next slide, please. So this is a map of Australia, and as you can see, you're actually closer to Darwin from Ambon than where I live in the middle of New South Wales. There's a map of New South Wales, which is approximately 10% of the geographical area of Australia. Western New South Wales Local Health District is the blue part of New South Wales, which is 31% of the land mass, and that's the area where our service covers. Next slide, please. Western New South Wales Local Health District has a population of 284,000 people, and that equates to approximately 1 person per square kilometre. So our population is quite dispersed. We are really fortunate to have 38 hospitals across our footprint, and they range in size and the resources that they have. There's 3 larger regional hospitals, that being Dubbo, Bathurst and Orange. And for our district, the referral pathways seem to go into those regional centres. Those regional centres have services like radiology, CT, surgery, birthing, and critical care services. Otherwise, the referral pathways for our district go to Sydney. So Sydney's about an hour flight or anywhere from 5, 6, 7 hour drive from our area. In Sydney, people go to Sydney for larger operations and specialist services like cardiothoracic surgery. Our population in Western is growing in volume. We have an ageing population. We have a higher rate of chronic and complex conditions, and the mortality rate for people in rural and regional areas is higher than people living in cities. We have a workforce of around 7,000 people, and we have workforce issues as well. We have a lack of doctors and a lack of nurses and a lack of skills in rural and remote areas. Next slide, please. So that was really the case for change, which led to our virtual services in Western. The original models of care started in 2006, and it really started out of necessity rather than just an option. It was needed. The original leaders of the service had courage and they had a vision. They wanted to reach the far corners of our district and provide equitable access to care. So in 2006, they centrally started a service that was run by nurses, and basically we coordinated care centrally for the whole district. So it's very much a patient flow access unit, but doctors and nurses rang by telephone to the patient flow and transport unit when they needed to refer a patient to a higher level of care. They were able to speak to a doctor over the telephone, get advice, work out where the patient needed to go, and then we would also organise transport as well. So we would wrap up the whole coordination for that patient. In 2008, an intensive care doctor had a desire to take critical care services to the far corners of our district. A lot of our hospitals, well 35 in fact, don't have specialists. They don't have intensive care doctors or emergency specialists. So he decided he wanted to take critical care services to those smaller hospitals and those populations. So in 2008, they put in cameras in all of the emergency departments, and I'll show you a little bit later what they look like from our end. Over the years, the service became busier and busier. I think providing a credible service and good quality care, the engagement with the frontline staff basically grew, and our capacity or our demand grew as well. So with that, we introduced a medical model. So we have doctors that work for us, and there's been a whole lot of changes in innovation over the years. We're now a 24/7 service. We encompass logistics, we encompass a single point of access. We have one 1-800 number to access the whole service. And today it's called the Western Virtual Division. Thank you. No, I was hoping there might be a video that might play. No, it's not working.
Western Virtual Division today provides a variety of services spanning emergency critical care to care in a person's home. The services are delivered by expert specialist clinicians in nursing, medicine and allied health. Our model is the Nerve Centre for coordination and response for people needing to access specialist care that cannot be provided locally. Our maturation over the last 2 years has realised many benefits and successes that you will hear more about today. However, we have also experienced a number of challenges, particularly...
That's okay, you did well. That's okay. So basically what you can see on the slide is the models of care that we have today. And the audio that you heard was our Director of Western Virtual, Megan Connors, that some of you met last December when you visited Orange. So basically today, there's a number of different models of care that I'll go through in a little bit more detail that encompasses Western Virtual. And really what we do is about human-centred care. So some of the models are inpatient models, some are outpatient models, some are emergency, critical care, some are non-emergency. So there's a range of models of care now, and they've basically been adopted over the years in response to the need of the communities. Oh, that's the slide. Yep. So that just shows the different models of care and the different functions and the different settings that we cover in Western. And the people is at the heart of it. That includes the workforce as well. Okay, so the emergency, critical care, patient flow and access, and remote monitoring. So this is our office in Dubbo. As you can see, there is lots of computers. It didn't look like that 10 years ago or longer. It was a lot more basic, I guess you could say. But with time and advancements in technology and services grow, so does the infrastructure like that. So basically, from the hub there, we run an emergency virtual service. Just to probably explain that a little bit better, I'll explain a scenario. So for example, if there was a patient in a rural hospital and they presented to the emergency department with chest pain, that emergency department may or may not have a doctor. So the nurse, for example, would triage the patient and assess them and start care. They would realise that this patient is serious and they need help. So they would call our 1-800 number. They would have a headset on so they can be at the bedside, and they would have the camera on, which you saw a little bit earlier. Our nurses answer the phone. We triage the calls basically, make sure the technology is set up. We then pop them into a teleconference, bring in our emergency consultant, and there's a conversation and handover about clinical management of the patient. If it's a STEMI or a heart attack, we would bring in the cardiologist. We can bring in any number of specialists to that teleconference, if you like, to make sure that the patient's getting the right care at the right time. Whilst the clinical handover and the communication's happening, we're watching on the camera so we can see the patient. We're watching their behaviours, I suppose, their work of breathing, their colour, and we can also see the activities of the staff around the bedside. So if they're performing a procedure that they haven't done before, we can talk them through it because we have a critical care nurse and a doctor on the phone supporting them. So we go through the management plan, we organise transport, and we organise the transfer to the destination for that patient. It would be somewhere with a cath lab so the patient can have an angiogram. We also follow up with that patient, and whilst that patient is waiting for transport, we have a proactive remote monitoring service. So the data from the patient, their vital sign data and the pathology comes through to a software called eCare Manager. So an AI, if you like, artificial intelligence. So one of our staff members can watch the patient and look for any signs of deterioration. If they deteriorate, we can ring, intervene, and make sure we're there to help them. So that's been a game changer as well in the last few years. I think that's all for that slide. Thank you. We are fortunate to have a good transport system in Western. So our service coordinates all of the transport. We partner with the emergency transport systems, New South Wales Ambulance. But for non-emergency transport, we have a fleet of 19 vehicles. That's the back of one of the vehicles there with the equipment. We can take 2 patients on a stretcher and we can have one sitting in front. In the transport system, it's really about matching the patient's needs with the resources. So we want to maintain that continuity of care between hospitals. Sometimes that's really difficult. Resources are few and far between some days, and we have problems with weather as well. But we're lucky to have that transport system. Next slide, please. Connecting care in the community. Planned Care for Better Health is a district-wide community-based navigation and coordination program for vulnerable people over the age of 16 with complex health and social needs. The team includes registered nurses and Aboriginal health clinicians that undertake a health and social care assessment and establish goals. So they connect people from the hospital environment to the community. The program goes for 12 weeks, and it's really about reducing the length of stay in our hospitals and trying to integrate people back into their community and avoid presenting back into the emergency departments. Thank you. Virtual Allied Health Service. So there's a number of disciplines in this service. It started quite a few years ago, but COVID really propelled this service. There's about 21 sites across the district that don't have allied health staff at all, and that's where this service really comes into the forefront. Thank you. Virtual Adults Regional Hub. This is a relatively new service. We're hosts. It's a state-run program. And the principle is single front door. So people from their home can access this service through a single 1-800 number. They speak to our nurses, our doctors from their home, basically. And it's about avoiding ED and access to care from their home. Thank you. Virtual Rural Generalist. This service is for the low acuity patients, and the Rural Generalists cover the emergency departments, and they can also cover the inpatients as well. They use video conference for every consultation, and there's been great patient outcomes and also clinician experience from this service. Clinical applications. Just going back to the camera. So this is our camera basically above every ED department. So from our end, we log into an application on the computer, and we can control the camera and move it to different parts of the room to see what is happening in real time. It's a game changer. Some of the other applications we use are electronic medical records, anything that we can find inpatient information to help formulate a plan and assess the patient. We also document every consultation in the electronic medical record as well. When we originally started the service, we were using paper notes for years and years. So it's taken us a long time to be able to document in the electronic medical record. We used a whiteboard, paper, very simple systems, but it's grown over the years. This is just a snapshot of service provision on an average weekday. So across the board, there's a fair bit happening. Allied health teams see about 10 people a day. Our vehicles drive over 4,000 kilometres a day. There's many people moving. We don't move everybody though. We sometimes avoid transfers because we can provide the care that they need where they are. Thank you. Some of the key enablers: leadership and executive support. You absolutely need someone to have the courage and to drive change basically and maintain that change. You need to have system knowledge. So we are very focused on our team understanding rurality and rural communities, and also understanding the technology that we use. We need to have good partnerships. Our stakeholder map is very large, and we need to have really good relationships with all of our partnerships. And we need to stay focused on our purpose, what is the case for change, and stick to our role and responsibilities. Thank you. Some of the challenges. Virtual care is expensive, especially when you talk about some of the AI systems. So it's about thinking sustainability into the future and doing more with less and being practical in your approach to virtual care. There's a lot of change happening all the time, so it's about strengthening the foundations of what you do amidst the constant evolution. Data capture and reporting is a challenge in virtual care, but we are working on that. And there's a fair few myths and expectations, but we are resolving those with communications and good partnerships. Thank you. Lessons learnt. Reflective practice. You need to be vulnerable. We make mistakes every day, but you need to look at what you do well and what you can do better. You need to have the right person for the right job. Virtual care is not for everybody. You can develop skills and knowledge, but it's having that right person. You need to build trust and you need to build capability. It's hard to build a rapport with people over a very short consultation, so it's about building a relationship with the partners outside of that care episode. And above everything else, it's about patient safety and quality care. These models of care have not been about saving money, it's been about providing safe care and high quality care regardless of where you live. Thank you. That's some of our publications and research that has occurred over the years. And thank you very much. I appreciate that.
Thank you very much, Amanda. Check. Okay, ladies and gentlemen, there will be a slight change of the program. Please give a big round of applause again to Amanda. And we are fortunate to have actually one speaker from the Netherlands who's already joining us in Zoom. Can you please display the speakers? Sorry. It's supposed to be in the third plenary session. However, because he is already online, maybe he can join the second plenary session with us. And I would like to introduce our third speaker for this session. Prof. Yan, good morning. Sorry, Prof. Yan, I couldn't hear you. Maybe your audio.
Good morning. Can you hear me now?
Yes, now I can hear you.
Okay.
Prof. Yan, Christiana here. How are you going?
I'm good. It's a little bit early, but...
Prof. Yan, what time is it in the Netherlands?
It's 3 a.m.
Holy. 3 a.m. Okay. Oh my God. So a very good early morning, Prof. Yan, from Ambon. And thank you so much for allowing us to listen to your presentation today. So maybe
Okay, most welcome. Thank you for inviting me.
Yes, Prof. Yan, maybe before you start, do you mind if you can just briefly introduce you with the profile of Prof. Yan, the IT team? Can you please do it? Okay. Ladies and gentlemen, please welcome Prof. Yan Nouwen, MD, PhD. He's from the Netherlands, from Erasmus Medical Center. Let me just stand here. So, Prof. Yan is adjunct professor of infectious diseases at Faculty of Medicine, Universitas Indonesia, Jakarta, and Faculty of Medicine, Universitas Hasanuddin Unhas Makassar. He's also adjunct professor of global health at Fakultas Kedokteran Universitas Airlangga UNER Surabaya. He is a full staff member of the Departments of Medical Microbiology and Infectious Diseases and Internal Medicine Infectious Diseases section of Erasmus in the Netherlands. Prof. Yan obtained his medical degree from Erasmus University of Rotterdam and Master of Science degree in Clinical Epidemiology and PhD on determinants, risk, and dynamics of Staphylococcus aureus nasal carriage. So without further ado, Prof. Yan, we would like you to start the presentation. There will be 20 minutes for you to present. Can you just please let us know if you can hear me clearly?
I can hear you very clearly. Can you hear me clearly also?
Yes, thank you very much, Prof. Yan.
Okay.
The screen is yours. Thank you.
Okay, thank you very much. So, just for the logistics, my presentation is up over there already, or I don't have to share my screen then, huh? If
IT people, are we sharing or Prof. Jan is sharing? We are sharing. Prof. Jan, we will share your screen. If it's okay? Yes, thank you.
So thank you very much, and thank you very much for inviting me. So although it's early morning here, I'm happy to join. Next slide, please. So the title of my talk is Antimicrobial Resistance: A Threat to Global Health. Next slide. We can skip that one because I was already introduced. So so what I want to talk about first is about global health. And if you look in, check the news regularly, then you would think that within global health, things are not going as well as supposed to be. But I'm not sure. Next slide, please. I'm not sure if you are familiar with this book from Hans Rosling and his family, Factfulness. Next slide. Because the subtitle of that book is 10 Reasons Why We're Wrong About the World and Why Things Are Better than You Think. And it sounds perhaps a little bit strange in the world we're living in today, but if you look at facts and figures, and that was what Hans Rosling was arguing about and is arguing about in this book, next slide, is that if you check data like vaccination status of children, like life expectancy on average in the world, like smallpox vaccination or eradication, like hunger, then you see that every variable you look at from the 1800s till the 2000s, so the last 200 years, has been positive. I mean, smallpox has been eradicated. Far few people are hungry. Still, there are many people hungry, so we should do something about that. Life expectancy has increased dramatically, as well as vaccination status. So if you listen to the news, then there are only bad things. If you look at the data, then you can say that in the last 100, 200 years, things have really improved if you look at health and at global health. Next slide, please. But of course, challenges remain. Many challenges remain, and we should focus on trying to solve these. Next slide. So Hans Rosling also in his book says that there are some things which could reverse all the positive developments we've seen for the last 200 years. So one is climate change. Next slide. And of course, we all know what climate change can do to our planet, like loss in biodiversity, nutrition excess, water use or water excess, soil degradation, and an estimated 250,000 people per year who will die from the effects of climate change. Next one. And of course, we also see the effects of climate change in the emerging infectious diseases we've been witnessing for the last, let's say, 2-3 decades. Next slide, please. So we've seen dengue, which has spread all over the world. Dengue even established itself in the southern part of Europe a couple of years ago already. Next slide. Chikungunya, next one you can click on now. SARS, long time ago already, 2003. Next slide. Avian influenza, next slide. Middle East respiratory syncytial virus. Ebola, of course, in 2014. Next slide. Zika, mainly then in South America. Next slide. Yellow fever, and the last one. And then, of course, in 2020, so 5 years ago, next one. COVID, with all the effects we're still witnessing from that pandemic. Next slide, please. The other effect which could reverse these developments, he says, is war. And of course, we're witnessing war at several parts in the world, dramatically influencing lives of people directly, but also influencing economic trade and whatever. And if that continues, then of course these effects will reverse the developments we've seen in global health. Next slide. And I mean, this man is in the news too often, I think, and perhaps we all should ignore him, but we cannot, because next slide. Not sure if you read this paper, which was just recently published in the Lancet, which is an estimation of what the effects are of the abolishing of USAID and stopping of PEPFAR and other programs the US is supporting worldwide so far, which will lead to 25 million deaths in the coming 15 years if the US really ends all global health funding as it is thinking of doing at the moment. And this is really is an unimaginable number, I would say. Next slide. And if you look at infectious diseases, and I'm an infectious disease specialist, so that's the first thing I look at, then you will see that in the field of HIV/AIDS, in the coming 15 years, without these support from the initiatives from the United States like PEPFAR, 50 million people will die the coming 15 years. So, I mean, again, unimaginable numbers and clearly policies which reverse all the effects, all the positive effects we've seen for the last 200 years in global health. And this one, I think, was what Hans Rosling wasn't thinking of when he said some things could reverse this, probably not thinking of a US president doing the most damage to these developments. Next slide, please. So one other thing is antimicrobial resistance. And of course, you've all heard about antimicrobial resistance. Next slide, please. And I think you all also know that the most dramatic effect on antimicrobial resistance is the overprescription of antibiotics by doctors, poor infection controls in hospitals and clinics, lack of hygiene and poor sanitation, the overuse of antibiotics in livestock and fish farming, and lack of antibiotics in the pipeline of pharmaceutical industries. Next slide. Another Lancet paper a couple of years ago already estimated that if we don't stop these developments in antimicrobial resistance, that from 2050 on, so that's in 25 years from now, 10 million people will die from infections with antimicrobial resistant microorganisms per year, with the most deaths occurring in Asia and Africa, and the global north, like Europe and North America, being hit less, much less than the other continents. Next slide, please. And what it also shows is this figure, like these 10 million deaths per year in AMR are more than the global deaths in cancer or cardiovascular disease or in any other disease category you could think about. So from this report, you would think that AMR is really a problem, is really going to be a huge problem if we don't try to halt these developments in antimicrobial. Next slide. And so antimicrobial resistance is a real global problem. Next slide. And it's a serious threat to global health. We see, and it requires actions from governments and also from society, not only from the medical fields, but also from other fields involved. Next slide. And it threatens effective prevention and treatment of an increasing range of infections by bacteria mainly, but also parasites, viruses, think of HIV again, and fungi. Next slide. And the other thing which will happen if we don't hold this issue is that without effective antibiotics, we will be back to the era before penicillin was discovered in the 1940s, and then thereby limiting the options we have generally in healthcare. I mean, the majority of elective surgeries depend on effective antimicrobial prophylaxis and treatment of infections postoperatively. They depend on patients receiving chemotherapy who, during neutropenia in their chemotherapy, after chemotherapy, develop infections. And if we cannot treat patients with effective antibiotics, we cannot do elective surgeries anymore, and we certainly cannot treat cancer patients with chemotherapy because of untreatable infectious complications that would occur. So healthcare would really be very different if we would have no antibiotics available anymore to treat infections, and really would put us back to the era before the discovery of penicillin. Next slide. And at the same time, of course, if you have complications with infections caused by antimicrobial resistant microorganisms, then patients will have to stay longer in the hospital, which increase cost of healthcare, and additional tests and the use of more expensive will need to be used, again increasing the cost of healthcare. Next slide. So what can we do? I think we know what we need to do. The only issue is that we should do it, and we should do it in the right way. So this is a picture of Desiderius Erasmus. He's the name giver of our university, and one of his quotes a long time ago was already, "Prevention is better than cure." And I think that it starts, of course, with prevention. Next slide. And of course, infection prevention and control is key for that. If we do not do adequate infection prevention and control, if we do not do adequate hand hygiene, if we do not adequately isolate patients with resistant microorganisms, then the spread of these microorganisms within hospitals from patient to patient will continue to occur. So this is first pillar of the prevention of the spread of antimicrobial resistant microorganisms from patient to patients within communities, outside the hospital, but certainly within patient populations in the hospital. Next slide, please. And of course, so I'm from Rotterdam, from Erasmus Medical Center. We've had a new hospital built a couple of years ago. It opened up 7 years ago. And this hospital has only one patient rooms. So there's one patient per room, making it the ideal hospital if you talk about isolation precautions you can take if you have a patient with an antimicrobial resistant microorganism. It was also a hospital which opened 2 years before the COVID pandemic. And during the pandemic, this was really a huge advantage of being able to take care of patients being isolated in their own rooms, and preventing spread of COVID in this case from patient to patient and from patient to personnel and the other way around. So having the possibility of building such an hospital greatly increases, of course, your opportunities to have proper infection prevention and control. Next slide. As in contrast, if you have to work in an emergency ward or an ICU like this, you can imagine easily that the spread of microorganisms from one patient to another is waiting to occur. So hand hygiene is important, but also the way we develop and build our hospitals will be key in the future to prevent the spread of antimicrobial resistant microorganisms. Next slide. And then the other thing is diagnostics. If you don't have proper diagnostic tools to detect antimicrobial-resistant microorganisms or infections with resistant microorganisms occurring, then of course it's also difficult on the one hand to treat patients adequately, and on the other hand to perform effective infection prevention and control. Next slide. So if you have a laboratory like this, full-fledged with all basic microbiology, but also advanced microbiology, molecular techniques, then you're in a lucky position, and you're in a position that you can detect these microorganisms properly and have adequate treatment and adequate infection control implemented for specific patients. Next. But if this is your microbiology lab, you can imagine that this is much more difficult to perform, even impossible to perform if you look at the current resistant microorganisms circulating. Next slide. And then antimicrobial stewardship, which is of course all about treatment and how we doctors treat our patients. Doctors also in the Netherlands thinking that meropenem is the best antibiotic you can give patients, so you should give all patients meropenem. Also for penicillin-sensitive microorganisms. And if that's in the brain of the doctor, then you can imagine that there is a lot of overprescription of broad-spectrum antibiotics, again increasing the occurrence of antimicrobial resistance. Next slide. And as said already earlier, we know what we should do. We know how we should do it. I mean, this is a graph looking at daily doses of antibiotics within the European Union. From the left is Greece, the country where doctors prescribe the most antibiotics. On the right side is in green the Netherlands, the country where doctors prescribe the least antibiotics. And this prescription rate of antibiotics by doctors relates directly to antimicrobial resistance occurring in these countries. Next slide, please. Because this is just a graph from the European Center for Disease Control, the ECDC, about the occurrence of the prevalence of MRSA in countries within the European Union. And you see that this tiny country where I'm from, the Netherlands, is green, marking that the prevalence of MRSA is less than 1%, and comparing that with Greece and Romania and Italy, where you see that it is between 25 to 50 or even above 50%. So prescription rate of antibiotics is directly associated with the occurrence of prevalence of antimicrobial resistance within these countries. Next slide, please. Now, the earlier report in the Lancet I referred to, stating that in 2050, 10 million people would die from infections with antimicrobial-resistant microorganisms, got a lot of critique. And many people said, this is PR from the infectious disease people. This is just to generate money for research, funding for all kinds of projects. But this 10 million is really a huge overestimation of what will happen. This is a study which also occurred in the Lancet already 3 years ago. A study which is a global study on antimicrobial resistance in the year 2019, so just before COVID happened. And what came out of this study is that in 2019 already, 5 million people died from bacterial antimicrobial resistance. So not including TB, not including HIV and all the resistant problems these diseases carry with them as well. But bacterial AMR already was associated with a death rate of 5 million people in 2019. Next slide. And what this study also showed was that AMR is a leading cause of disease around the world, with the highest burden, again, which was predicted also with the Lancet report earlier, in low resource settings. And that the main efforts we should put in to prevent the spread of antimicrobial resistance was infection prevention and control, access to essential antibiotics, new vaccines and antibiotics, and expanding microbiology laboratory capacity, because if we are not going to do these things, then the spread of AMR will only continue. Next slide, please. So to conclude, next slide. AMR is a real global health problem. I mean, you cannot deny it. Whatever country you go to, if it's the Netherlands or Indonesia or any country in between, you will find that AMR is an increasing problem. Next slide. And it is a problem which is affecting all of us. It's increasing the cost of healthcare. Patients have to stay longer in hospitals. Mortality goes up already now, not only as predicted in 2050, but already now in this area. And we know what we can do about it. We need good infection prevention. So training of healthcare workers is essential, but also how we build future hospitals, which will be essential to contain the spread of AMR. We need good microbiological diagnostics, because if we cannot diagnose AMR, we cannot do anything in prevention and treatment, and not again halt the spread of AMR. We need good antimicrobial stewardship for the current antibiotics, but certainly also for the new antibiotics that are being developed. Luckily, we will have new antibiotics, mostly old antibiotics packaged in a new way, but still. And I think we need a good infectious disease consultation service within the hospital, where doctors, surgeons, internal medicine doctors, gynecologists, and whatever are in close collaborations with microbiologists and clinical pathologists about diagnosing infectious diseases and coming up with proper advice on antimicrobial treatment within the hospital setting. Next slide. And outside the healthcare setting, of course, there's a need for a multidisciplinary approach, because livestock and fish farming is associated with a huge antimicrobial use and a huge burden of antimicrobial resistant microorganisms. So we need not only look at the human side, but we also need to look at the veterinarian side in a One Health approach. Next slide. And of course, as doctors, we should think of doing something else than prescribing new antibiotics. Like this doctor is trying to write a sonnet to his patient. Or next slide. We can rely on how patients act on using their antibiotics, and during an infection. In this case, this patient wanted to surprise the bacteria by taking her antibiotics earlier than prescribed. But of course, you can imagine this is not going to work. Next slide. And one thing to add on that is, I showed you earlier on all these viruses which are spreading also in relation to climate change, etc. We've had this COVID-19 pandemic, and we know that during the pandemic, many patients have been admitted to hospitals. We know COVID-19 is and was a virus, so antibiotics won't do anything. Still, many patients admitted to the hospital with COVID-19 infection were treated with antibiotics, because doctors are still afraid that you would miss a bacterial infection in a patient with COVID-19. So there was a huge overuse of antibiotics during the years of the pandemic, 2020, 21, 22, leading probably to an increase in the spread of antimicrobial resistance worldwide. Next slide. So I show you these data in 2019, 5 million people dying from AMR in 2019. Next slide. But the question really is, what is the current figure? And in my opinion, if it's 5 million in 2019, then probably it's much higher in 25, after the huge overuse of antibiotics in the pandemic COVID period. So again, in global health, AMR is a real global health issue. We know what we do, but we should start acting and doing the things we know work to prevent the spread of AMR and to prevent its effects on healthcare and global health for the coming years. Next slide, please. And with that, I would like to say thank you very much. And if there will be questions now or later on, I will hear that from you, I think. I will
Thank you
be happy
very
to take them.
much. Thank you very much, Prof. Jan, and please give a big round of applause to Prof. Jan and Amanda. Now we are coming to the question and answer session. We will receive questions for both speakers. We give you like 3 maybe questions per speaker. Please raise your hand and you can walk to the front microphone. Yes, Dr. Oni? 1. Ibu Juen? 2. Ibu Melda? 3. Dr. Oni, please, you can move up front.
Yeah, thank you so much, Doctor. I would like to ask for the antimicrobial resistance. I imagine about in the future we would be scientists or researchers, and then you talk about the new antibiotics, and this is the resolve thing that we can conduct to solve antimicrobial resistance, but I think it's very expensive if we do the new antibiotic. So my question is, what is the field for us as a student or a scientist in the near future probably to solve the antimicrobial resistance? Thank you so much.
Thank you very much, Dr. Roni. Prof. Jan, can you hear the question?
Yeah, I can hear the
Oh,
question.
yes.
So the question really relates to, is our new antibiotics the solution for the AMR problem?
Yes. Do you
And
mind
they're not.
answering straight away? Yeah, please.
Yeah, they're not. So I mean, I completely agree with the one who asked the question, is that we need new antibiotics because in some cases, in some microorganisms, we are out of antibiotics. I mean, there are microorganisms circulating also in Indonesian hospitals which are untreatable. And for patients with these type of infections with these microorganisms, we need new antibiotics because otherwise they will die from these untreatable infections. So that's one part. But if we continue the way we've been using antibiotics for the last, let's say, 50, 60 years, then in no time there will also be resistant development against these newer antibiotics. So these new antibiotics are, for the long run, certainly not the solution, but as part of trying to take care for patients the best we can, we need them. But I mean, prevention is always what I said. Prevention is always better than cure, and prevention is always cheaper than cure. So for students and for young doctors, I would just advise you: wash your hands, perform your hand hygiene well, and comply with infection prevention and control rules. And don't overuse the antibiotics you're prescribing to your patients.
Check. Thank you, Prof. Jan. Dr. Roni, so prevention is the key and don't overuse antibiotics. Thank you very much, Prof. Jan. Ibu Juen?
Yes, okay. Thank you, Prof. Yan, for your excellent presentation. You say that IMR now is global health problems and it's caused by the several factors, overuse and also the over of prescription. My question is how to overcome or solve the IMR issue in patient who are positive for some antibiotic resistant, and how we facing the challenge to get the best treatment for the patient. Thank you.
Thank you, Juan. Prof. Yan, can you hear the question?
Yeah, I can.
Okay.
I can hear the question. So
Thank you.
Thank you.
Please, Prof.
Thank you very much again. I think I answered that also before with the earlier question. I think that for individual patients, of course, you will have to look at the best options available. That means that you need a huge arsenal of the antibiotics we have currently available and also newer antibiotics in the pipeline. You need adequate microbiology tools, diagnostics, to be able to detect these microorganisms and their antimicrobial resistance, to be able to come up with a treatment plan for these patients. And for other patients, again, it means that you would have to that you would have to enforce infection prevention and control very strictly to prevent the spread of these resistant microorganisms. One issue which is I haven't been talking about in my presentation, but one thing which has been coming to the forefront the last couple of years also is that we tend to treat our patients too long. There are studies that community-acquired pneumonia can be treated with 3 days of antibiotics. Still, most guidelines say we would have to treat with 7 to 10 days. We know that hospital-acquired infections you can treat with antibiotics for 5 days. Still, we treat for 7 days or 10 days or 14 days. Urinary tract infections you can very often treat with only 1 day of antibiotics instead of, again, 7 days. So we should also look into doing more quality studies into the duration of antimicrobial treatment. And the studies that are out there show that we can really shorten duration and thereby using less antibiotics as well. So that will be another way to try to tackle this problem.
Thank you, Prof. Yan. And maybe for the next person, Ibu Melda? Or Ibu Melda, you can use this microphone.
Oh, yeah. Yeah. Again, Professor John Lowen, I would like to ask you, how promising is diagnostic stewardship in reducing unnecessary antibiotic use? And I just wonder, which nation in this world that are most vulnerable to antimicrobial resistance?
Ibu Melda, sorry, which one is more vulnerable?
Yeah.
Which nation? All right, okay.
Yeah.
Prof. Yan? So which nation is more vulnerable? Yeah.
Which country you mean?
Which country? Yeah.
So to come back to the first part, I mean, diagnostics is really important, and also trying to have your diagnostics results out as quickly as possible. I mean, in our setting, if we have a positive blood culture in a patient, we directly communicate with the treating physician on the ward. really shortening the time that a doctor asks for a culture and gets a result from the lab, and thereby speeding up adequate antimicrobial treatment. So diagnostics and the speed of your diagnostic process is very, very, very important. And with the current molecular techniques, there are really developments which can even further shorten the duration from the moment you do the blood culture, for instance, and the results you get out of it, making it easier to treat patients adequately with the proper antibiotics. So that's one part. But all these diagnostics cost money. Investments in adequate diagnostic laboratories cost money. And what the Lancet paper on antimicrobial resistance from a couple of years ago showed, and what the 2020 paper in the Lancet also showed very clearly, is that the countries which are most vulnerable to the AMR problem are resource-limited countries. So you see that the majority of patients getting sick and die from these infections will be in the African continent, and that also because of the huge numbers, the population size also in Asia, but that has less to do with resource settings, but more to do with the population size. But which country is the most vulnerable? So low and middle income countries with limited resources, and also countries where investing in healthcare and investing in prevention is not in the mind of the government. So if your Minister of Health is very eager to have all kinds of modern diagnostics and treatment facilities up and running in the country, but forgets to invest in basic facilities like diagnostic tools for, in this case, microbiology, then that would not be a good way to go, in my opinion. So it depends on the money you have, foremost, and it also depends on choices governments make in investing that money in healthcare and where they want to put their money.
Thank you very much, Prof. Yan. Any more questions from the floor? Yes, Joanne? Yes. And Dr. Jerome? So maybe that's the last two questions from the floor because of the time constraint. Thank you very much.
Thank you very much for the opportunity. I would like to address my question to Amanda Hunter. Thank you very much for such an amazing presentation. I'm in awe with the technology that you shared. And based on that, I want to ask you, based on your experience, what aspect of the Western Virtual Division model could be adapted to improve healthcare accessibility in rural or island regions like Ambon in Indonesia? Is my question clear?
Amanda will answer it straight away.
Thank you.
I think probably the GP model is probably quite accessible to turn on. So you need a healthcare worker with the patient, or you could have the person in the outpatient setting from their home by themselves without a healthcare worker, but a healthcare worker with the patient would assist, gather that information that you need about the physical assessment, and then until you get connectivity with a better internet, connect by telephone. In virtual care, face-to-face or seeing a person, seeing the patient is best practice, but you need a fair bit of data for that. So until you can get that, having that phone advice and information over the phone would be great. You can get a lot of information, particularly if you've got someone with the patient to, check their pulse, or, have they got a temperature, or some simple sort of physical assessment information like that.
Yeah. Yeah. Thank you very much, Amanda. Well, you know, sometimes, like for us in Ambon, we would like to see a person rather than listening only to their voice. And it's better to see them. That's why sometimes telemedicine is also very hard to implement here because of the limitation of technology, infrastructure, but also, like, I want to see them. Like, I want to talk to them rather than I just listen to whatever they're saying.
Or just even talking to a patient, you can hear by the tone of their voice, you know, can nearly hear their breathing over the telephone. So you can pick up a lot of cues like that as well. Yeah.
Okay. Thank you, Dr. Jerome. That's the last, maybe the last question for this plenary session.
Okay. Thank you so much, Dr. Ate, for the opportunity. Thank you, Amanda, addressed these two questions for you. Thank you so much for an amazing presentation. I know we can learn a lot from what you have been doing in Australia. One thing that sparked my interest is the transformation that has been running since 2006 to until now. And what was the driving force, the core value that keeps the transformation going, and how do you define this for the success of your program? The second one is I noticed that at certain circumstances, both in Indonesia and especially in Ambon, and also Australia, we fall under the same problem, and one of them is the shortage in healthcare workers. And what are the prevention or the solution that you can provide to address this issue? Thank you so much.
Thank you, Dr. Jerome. Dr. Jerome has two questions, maybe could be addressed by Amanda directly.
Thank you for the question. So address the first one. So what was the driving force for the transformation from 2006? I guess it's having rural people deliver rural care. So you have to feel it. You have to have the purpose within you to make a difference. So I would say that would be the main difference. I guess over time, you see the results and you see how you make a difference. And it's not just at a one sort of patient one-on-one, well, there's that as well, but it's actually a system level difference. So you start to see changes that motivates you to keep going. And I guess there's just so much change. It is an exciting field. Technology, research, it never stops. Then there's global pressures. There's nothing like a good global pandemic to light the fire again. So COVID absolutely lifted the lid off our service, and all of a sudden the community, there was no other option but to connect via technology for lots of different things, for education, health, you name it. So that made the acceptance in the community a lot wider. So there's lots of different factors, I guess, to drive that change and drive that transformation. But I guess for the team that I work with, it comes from within, from living in rural areas, understanding rural communities, and wanting to help our own people. For the second question about healthcare workers and the workforce shortages and skill limitations, how do we prevent that and what's the solution? It's a tough one. I guess we're not alone. It's just remembering that it's a global problem, so don't feel alone. Do what we're doing, reach out, make friends, share knowledge. I don't think we have the answer yet. We've tried a number of different things over the years. So workforce culture is very important. So it's about looking after ourselves as well, and that work-life balance, and trying to sort of get longevity out of your career. Education helps. We never stop learning. So there's always opportunities to learn and grow, and I think that motivates us. For the rural workforce, we have a big role in supporting the education of the rural workforce in real time, because we're helping them with best practice pathways and supporting them in practical ways of when they need to do tasks or skills that they haven't done before. So we're talking them through that and helping them. We run simulations and we debrief with the team after a critical event. We unpack it, help them process things. So I guess supporting the rural workforce, we don't replace anyone. We refer to ourselves as an extension of the bedside team, and we work together. For our own workforce, just in the last 12 months, we've facilitated some of our nurses to work remotely. We had a number of years for nurses, so some of them work in Sydney, some of them work down the south coast. But we're very stubborn on making sure that they understand rural. So we spend a lot of time focusing on rural people and geography and their care needs and how it's different from the city, our processes and systems. So we make sure, regardless of where people work, that we have a high level of skill and experience and that they understand rural and remote healthcare. Thank you.
Thank you very much, Amanda. That is inspiring, I think. And to see when Dr. Jerome asked about the driving force, maybe I can quote from yesterday's presentation, like it's really the love. It's really the love to help others. So to make sure no one is left behind and no island is left behind. Yeah. Thank you very much. I think that concludes our session for this morning. Thank you again to Amanda. Prof Yan, thank you very much. Terima kasih banyak, Prof Yan, dari Ambon.
Terima kasih.
Terima kasih. Terima kasih. And maybe, Prof Yan, can you please wait a minute? There will be a token of appreciation given to Prof Yan online. Yes, this is the certificate, Prof Yan, from all of us in Ambon. Best wishes, and now it's time for you to sleep, perhaps.
I will go back to bed.
Yes.
Thank you very much.
Thank you. Have a good rest.
Okay.
Thank you, Prof Yan.
Thank you.
Bye. And I would like to invite the Dean of Faculty of Medicine, Dr. Berta, to present the token of appreciation to Amanda. Can the IT team help with the screen?
Once again, thank you to our distinguished speakers for the insightful and thought-provoking presentations, and to our moderator for skillful guiding today's sessions. with clarity and poise.
Ladies and gentlemen, we will now take a short 10 minutes break. If you wish to use the restroom, please feel free, and our team will assist you, and we will reconvene shortly for our plenary session 3. Thank you very much, and we'll see you after the break. Ladies and gentlemen, we cordially invite you to be seated at the prescribed chair in the main hall because in a few minutes the ceremony will proceed in no time.
Hadirin yang kami hormati, kami mengundang masuk kembali ke dalam ballroom karena dalam beberapa menit ke depan acara akan segera dilanjutkan. Terima kasih.
Ini Bapak Ibu, ini kegiatan main koral dengan Malaysia di HTW Besar. Ini bersama MSU, Malaysia dan Bupati melakukan restorasi koral.
Welcome back, ladies and gentlemen. We will now continue with the plenary session 3, entitled Collaborative Action, Addressing Antimicrobial Resistance, Malaria, and the Role of Herbal Medicine in Archipelago Communities. These sessions will be led by our moderator, Dr. Karina Jaslyn Song, Master Biomedic Health Science. Dr. Karina is distinguished academic and currently serves as a lecturer at the Faculty of Medicine, Universitas Patimura. Dr. Karina obtained her medical degree in 2020 at Universitas Hasanuddin, followed by master degree in biomedical health science from Monash University. Please join us in welcoming plenary session 3, Dr. Karina Jaslyn Song, Magister Biomedical Health Science. Dr. Karina, the session is yours.
Check. Okay. So, good afternoon, everyone. Allow me to introduce myself. My name is Karina, and I'm very happy to welcome you to join the third panel session today with the title of Collaborative Action, Addressing Antimicrobial Resistance, Malaria, and the Role of Herbal Medicine in Archipelago Communities. So, without further ado, I will explain to you the guideline for the session. So each presenter will have 20 minutes for the presentation. And then after all the presenters present their presentation, we'll proceed with 15 minutes of Q&A session. So to start our panel session, it is my honor to introduce our second speaker, Dr. Elizabeth Farah Novita Cotrier. Dr. Farah is a researcher at the Eijkman Research Center for Molecular Biology, under the National Research and Innovation Agency of Indonesia. She has a strong academic background in biology and medical biology, with degrees from Universitas Indonesia and the University of Melbourne. Her doctoral research focused on host responses to malaria infection, and she has developed a strong research profile in malaria genetics and immunology. She is actively involved in understanding the genetic diversity of malaria and the human host response, which is critical for informing effective control and elimination strategies. Today, she will be sharing her insights on challenges in malaria elimination, a vital topic as we push towards global malaria education. Please welcome Dr. Farah. So the IT team can help us with the presentation. And when it's ready, Dr. Farah, the stage is yours.
Okay, thank you very much, Karin. Today my talk will focus on the challenges in malaria elimination. But because we need more research and innovation, I'm going also to discuss about the research and innovation to respond to malaria elimination and other health changes. Next, please. So, as pictured there, we have a lot of strategy and position in our aim to achieve malaria elimination in 2030, which is only 5 years from now. But there is a lot of challenges to focus to face this malaria elimination. Mostly in diagnostic, we still have some misdiagnosis because there is parasite who has mutation in its gene that makes RDT, rapid diagnostic test, cannot detect. So there is false negativity. And also in microscopy, more than the 4 malaria that has been known, falciparum, Fifax, malariae, and ovale, there are also increasing number of zoological malaria that infected us. It's transferred from the primates. And in terms of microscopy, it is difficult to detect those new type of malaria. And also in treatment, drug resistance, as we know, the chloroquine resistance happened, started in 1970s, and in 1990s, it's completely, already completely resistant. So we need to change to another medicine. Now the focus medicine is artemisinin, and at the moment we need to try to develop more medicines to be ready to overcome if there is more cases of drug resistance, which is in some areas in Thailand and in Africa, there are more detected gene that in falciparum that resistant to artemisinin. And in human, the diverse genetics of human in Indonesian is we have a lot of genetic differences, and one of the difference that will have different response in drug administration is the G6PD deficiency. With people who are deficient with G6PD, they cannot handle getting primaquine as medicine for malaria. So that's another challenge. and also low awareness of treatment diligence in taking Primaquine treatment for 5X infection. There is also risk of awareness in vector control and the activity without mosquito repellents at night when mosquitoes are actively challenging us, taking our blood meals, and bed nets for sleep, larval surveillance, etc. So I will discuss more about our approach in research to overcome those challenges. But since there is a lot of challenges, I'm going to cover only a few of them, and the rest we can see about different also medicals. So next slide, please. So in the map of endemicity of malaria in Indonesia is published by the Ministry of Health. Last year, it's shown that the most area in Papua has high endemicity, and in this picture, in Maluku, the endemicity of malaria is middle. Next. So this is more correct picture, and also it shows that the highly endemic areas are in Papua and in eastern Nusa Tenggara. Next. So last year, malaria mortality, it occurs the number is 125, and 52 of them are in Papua. And also in this picture, I highlight there is some mortality of malaria in Maluku, but since it's a low number, probably it's not a very big issue. So next. So we have research to overcome the challenges of malaria vector control in Papua by doing this approach in trying to identify what species of mosquito appear in Papua, and the result is there are 3 out of 11 species that we can recognize. 3 of them are very active. It happens in a lot of places, and it also have malaria parasite inside their guts. Also in the research is done both in the field and in the laboratory, and from laboratory molecular approach, we could identify that there are some genes in the mosquito that make them resistant to insecticide, pyronaridin. So there is the challenge. So what would be the conclusion and recommendation? Next, please. So the conclusion, because of the presence of both indoor and outdoor malaria transmission in we covered 8 high malaria endemic regencies in Papua province, and the 3 malaria vectors appears in most of the areas, and so the recommendation are to do indoor transmission strategy by installing mosquito screen on your windows so that the mosquito cannot come in freely. And also when you're sleeping at night, you use the insecticide treated bed nets. And inside of the houses, we can also apply indoor residual sprayings of insecticides. And the other approach is to use innovative vector interventions such as mosquito repellent. So when we want to go out at night, we use mosquito repellent. And to overcome the outdoor transmission, we can do more larva sources management, a routine clearance of pool, and increase the function of fish ponds in water pools. And also to increase the challenges, the educations in malaria overcoming. Next, please. And then with the, I mentioned about the zoonotic malaria. We did some research also in 5 areas outside Papua. And we found there are quite some number of primates that has malaria parasite inside their body. Even in Central Java, some primates, like 40%, we can find malaria parasite inside their body. But from this research, we found that 3 different species of apes has malaria, and mosquitoes also are Anopheles species that can transmit malaria. But from all the people that we also screen, none of them have malaria inside their body. So it's still a good news for us. Next, we also try to find the molecular basis to find resistance in the parasites of anti-malaria drugs, but we also find that the anti-malaria drug is still efficient in most areas in Indonesia. Next. And then with the genetics of genetic approach, we find that comparing the malaria knowledge, the zoonosis malaria parasite between Indonesia, which is Aceh, and Malaysia in areas of Peninsula and Sabah Sarawak, top of Borneo, there is quite difference from our populations compared to them. So it's our zoonosis knowledge parasites are a lot isolated in Aceh. Next. Yeah, there is some surveillance of zoonosis in North Kalimantan. Next. Discovery of anti-malarial drugs. So we also try to discover more anti-malaria drugs, potential anti-malaria drugs, and we screened the marine bacteria, associated bacteria, and this research is still ongoing. Next. So with other health factors, the research and innovation that we do next is to look at the, like Professor Yan mentioned, the pneumococcus, pneumonia bacteria are intended to get antimicrobial drug resistance. So we try to find whether in Indonesia, the immunizations against pneumonia, is it relevant with Indonesian type of bacteria, pneumococcus, and the result, the serotype 3, the genomic profile of the Streptococcus pneumonia in Indonesia also already shows some genetic mutations that makes them resistant. So it should be better if we can new vaccines productions. Next. In terms of zoonosis from rodent-borne disease, like the pest, leptospirosis, rickettsia, and hantavirus, we have molecular epidemiology research in Central Java and in East Java, and the output, the potential future outcome is to produce rapid and early detection methods to identify this type of pathogens. Next. And we also did molecular epidemiology and genomic characterizations of dengue viruses in Indonesia, and the results shown that in some part of Indonesia, the dengue serotype 2 is also present, which is almost not happened in other areas in the world. And that will also help in trying to produce more vaccine for dengue. Next. And also the chikungunya virus pathogens with the potential of antivirus candidate. We tried in challenging the viruses with alpha mangosteen, and it produced some potential effect from the mangosteen to become antivirus for treatment of chikungunya. Next. Also the serological detection of hepatitis. Next. Liquid biopsy for hepatocellular carcinoma. Next. And a lot more, like the gut microbiome. We do metagenomic test, and the microbiome will be a potential therapy for burn degrees. Next, and other non-infectious research topics, it's also present there. And all these results you can see by yourself from this flip book. You can just screen this QR code, and you will be able to look and see there. Unfortunately, the explanation in there, it's very similar with what I presented, but in Indonesian language, so I'm sorry. But yeah, I hope this can be very useful for everyone. Next, it will cover, so the inside will look like this. So there is also some issues about tuberculosis, about stunting, and how to manage a healthy food. Next. I see the clock is very fast, so I'm quite nervous. Sorry. So I'm just going to mention that our research, we come from the health organizations, also research organization for health. It is in BRIN now. And next, apart from Eichmann Research Center, we have 6 other research centers that has focused in research, biomedical, preclinical, and clinical medicine, Center for Public Health and Nutrition, Center for Pharmaceutical Ingredients and Traditional Medicine, Research Center for Vaccine and Drugs, and also Research Center for Veterinary Science. So I encourage everyone to collaborate in trying to do research and innovations in health issues that occurs in each areas. Next. Now, in each research, we need funding. And this is informations. You can log into that link, and it's funding that you can try to approach from the BRIN. And next. And it's also to increase our own knowledge. There is funding for degree by research for master and doctoral degree. Next. And it's what is covered in the research degree. Next. And what is needed to become one of the research achievement. Next. And there is this process of applying for this program. Next. This is a list of the universities that already collaborate with BRIN, but don't worry if your university or the ones that you intend to join is not there, we can still apply and they will open a collaboration. Next. So thank you. And on the left is the link for our website, the Eichmann Research Center for Molecular Medicine, and the right one is the website, the QR code for this book inside. So that's from me. Thank you.
So thank you so much, Dr. Farah, for your wonderful presentation. I think it is very interesting for us as well to know that the progress of the research in Eichmann. And it is very interesting to know that you are doing so much work, and thank you for that, because we all know that we have so many diseases in Indonesia, and we are working together to tackle that. So moving on to the second presenter. We will welcome Prof. Muhammad Fadli Muhammad Asmani, the Dean of the School of Pharmacy at the Management and Science University, or MSU, Malaysia. So Prof. Dr. Fadli is a highly respected educator and researcher in pharmacy practice and health sciences. He received academic training from UKM Malaysia, MSU Malaysia, and Jose University, Japan. So his teaching experience includes roles in Selangor Medical Center and Management and Science University. So he will present us a talk with title Healthcare Medicine. So please join me in welcome Prof. Dr. Fadli. So thank you so much, Prof. Fadli, for joining us today. So Prof. Fadli just landed here this morning. Thank you so much to fit us in your tight schedule, and you'll have to go directly after this. So thank you so much for making your time. So without further ado, Prof, the screen is yours.
Bismillahirrahmanirrahim. Very good mornings, and thank you very much for Dr. Karina for the very kind introductions. And I must say thank you very much to the Dean, the directors and the Dean to organize this conference. And that is why I must say I'm very sorry for them also, because I not able to come yesterday. Because in Malaysia, we do have our Prime Minister visit our university. Last minute, we got a notice. Then all the schedule is changed suddenly. Then I have to be there to attend our Prime Minister. Very good response, very good outcome from that visit. And thank you very much And I told myself that must come over here because I already promised I would like to join this conference, and I feel very bad if I not come over. That is why I decided to come over, even though tomorrow there is another meeting again. Very sorry about that, but I must say thank you very much for the invitation. Thank you, the Dean, Dr. Beta, Dr. Freddy, the Rector, thank you very much, and I hope it's not the first and the last for me. For information, this is my first time I came here to Ambon, and I feel very welcome, very good, and I feel like going back to my hometown in Malaysia, near coastal area. I born in Sungai Besar. Those who are from Malaysia, they know the Sungai Besar is nearer the coastal area. Tepi laut juga, keluarga nelayan juga. Then it is similar to me. Then I very interested and very happy to join this conference and come to Ambon. Thank you very much. Okay. I would like to start with my first slide. Okay. All right. Okay, this is a special I make. Thank you for Prof. Dr. Freddy and Dr. Beta from MSU, from our president, Tan Sri Presidents. For the information, the audience, MSU here, we have a student and also with Dr. Nizam. I think starting from 2 days ago, we do several projects, and that's why I think we have a very good collaboration with Universitas Patimura and MSU. So thank you very much for the invitations. And actually, my topic is talking about Christia vetulioris herbs. From the herb, hopefully we can find something, the pharmaceutical ingredient, like Dr. Farah said, we're looking to the pharmaceutical ingredient and related to the traditional medicines. This is my focus, but for that I would like to go for the introductions about herbal and diabetes in Malaysia. For the information, currently I do work with Chinese medicine, one of the university in China. I do the looking for the clinical trial data for the Liu Tong Ho medicines to treat kidney disease, CKD disease, for the stage 3 from the diabetes patient. Hopefully we can get something and we can publish the clinical data for using the Liu Tong Ho from Chinese medicine. That medication was been used more than 10 years in China, but there is no clinical data. But hopefully MSU can work with the China University when we publish the clinical data for that. So hopefully we can do something here with the Indonesia. We look into the clinical data for the herbal medicines. So to start with this, in Malaysia, herbal medicine is commonly used alongside conventional treatment for diabetes management. Why Malaysians love to use herbal? Because the cultural belief. Malaysians, in Bahasa, I believe many understand, it's orang kampung, the village. So we always go for the herbs, from akar kayu, daun-daun, pucuk, all this kind of things. So that's why this is related to cultural beliefs and easy to access, and the perceptions of the herbal drug is fewer side effect, not chemical. Malaysian really worried something to do with the chemical. They love natural product. So as we know, as a medical doctors, pharmacists, pharmacologists, we do understand that the effectiveness and safety of this herb is varies, and it's not really have some sort of strong evidence to support that. And maybe it may interact with the diabetes medication and so on. Yeah. Right. Okay, next. I would like to link this a few slide with the product currently become popular in Malaysia. If you notice here, there is in this slide, there is 4 common herbs being used to treat diabetes. Bitter melons, in Malaysia we call it peria katak. I thought it will be the same as Indonesia, they call peria as well. I don't know. I think so. Misai kucings, and then halba and ginseng. This is a 4 thing. All of this, their belief, can lower down the blood sugar, improving the insulin sensitivities, and also can good for the kidney, because we do understand the diabetes can lead to the kidney deteriorations, and also can be slow down the glucose absorptions like halba, and also improve, the main part is to improve the insulin sensitivity. That is what we believe among Malaysian toward the herbs in diabetes patients. Okay. Another herbs also is cinnamon, kayu manis, kunyit, and neem. If you notice from the first slide and this slide, you will see that this is common thing we are used in our food. It's daily, right? We use kunyit almost every day in our chicken, fish, and so on. And cinnamon, kayu manis for our food, and also for the kueh, cake, and so on. So all these things is, at the end, the scientists in Malaysia, the pharmacologists in Malaysia, their belief, they do the study, they do the research, is that there is a significant evidence to show that this kind of herb is play a role to reducing the blood glucose level and so on. So that is why, therefore, they go to produce, next slide, they go to produce, we call it nutraceutical product. And these nutraceuticals become very common and is a boom in Malaysia. If you go to the YouTube, you go to TikToks, you try to Google the most popular doctors, I dare not to mention the name, but you will find that a few medical doctors now, they really promote related to the nutraceuticals. Am I right, Malaysian student? There's a few doctors who have become popular talking about moringa, talking about all these kind of things. But actually it's related to nutraceutical. So from this few slides before that, starting from the beliefs, the accessibility, and also a few scientific data talking about the pharmacological activity. Clinical data does not there yet, but pharmacological data talking about the pharmacological activity is there. So we are here, medical doctors, pharmacists, we have to go further study, to go further research, to show there is a clinical data to prove that this kind of food and nutraceutical is very beneficial to the diabetes patients. So there is a thing. So if you look at that, of course, they are mainly for better glycemic control, improve insulin sensitivity, and reduce complications. And this is a common, what we call it, the active pharmacological ingredient, or API, ALA, alpha lipoic acid, berberine, omega-3, chromium polycyclic. This is a thing they claim they are active ingredient in nutraceutical product. So from the foods, they discover the molecular like berberine and so on, omega, and they are formulated as a pharmaceutical product, and they name it as a nutraceutical. And this kind of product become booms in Malaysia. And due to that, there is another ingredient play important role, including the probiotic and prebiotics, vitamin D, and so on. So due to that, the Malaysian government, they do the control. How they do the control? They do the registration of natural product. So in Malaysia now, we not only register the allopathy product, modern medicine product, we also register the natural product to control that. So if you notice, you get the Malaysian product at the back, at the T, MAL, and T stand for traditional. And also sometimes there is a few like cosmetic and so on. There is an indicator for us to tracking to make sure whatever product in Malaysia are being registered and have proved their safety and also not harm to the patient. But under the natural product, the registrations not really go for the efficacy yet. They only go for the toxicity and safety. So there is the room for medical doctors here, for pharmacists, maybe we can proceed further to look into the natural product, nutraceutical product. We do the research, we do the kind of data, analytic data to show there is the efficacy to treat of diabetes or to treat all other diseases, malaria and so on. This is the message from this slide. Okay, next. Okay, this is my topic. It's very simple topic, very simple study. We just look into the activity, antibiotic activity of Christia verpacitolis leaf extract using the metabolic approach. This is what we done in MSU. I think if you look at the prevalence diabetes in Malaysia now, starting from 2023, it shows that the diabetes patients was increased 15.6%. It's really alarming in Malaysia. And if you look at the consumption, medical product consumptions, also the highest consumptions, the highest cost the government to spend is one of it is diabetes, of cardiology, cardiac disease and diabetes and so on. One of these is diabetes. Okay, in our study, we focus on a plant, we call it Christia verpacitolis. And of course, the classification here is a common name in Malaysia. We call it pokok rama because the shape is like rama-rama, like butterfly. And then ethnobotanical use, they use as a traditional before. So from that, we heard they are used for tuberculosis, snake bite, and so on. So we keen to study is that plant can be used for diabetes patient or not. So end up we discovered by using the metabolic approach, we not really focus for the glucose level alone. We look into the metabolites indicator like taurolic acid, nitrosamine, oleic acid, and so on. We using that, and we will see the pathway, the effect. Either their metabolic is increased, goes up or goes down. Is there any significant difference or not? Yeah. So this is what we are looking for. So what we aim is to monitor the diabetes patient and to monitor the effectiveness of the drug. Is not only focus of the blood glucose level or HbA1c, but we also looking into the metabolite indicator. So if that, so this is I think everybody knows already what is the metabolomics. Has been widely used in detections and diagnosis and treatment of diabetes and has demonstrated a great benefit. So at the same time, study on diabetes also is very complications, and we discovered the metabolic marker characteristic of diabetes is very useful. So that is the reason why we go using the metabolic approach to look into the pharmacological activities of this plant. All right, next. Okay, this is a problem statement. Our research, we try to look into the alternative medicine beside normal medicine like veglicobos, miclotol, acarbose, and so on. So we looking for the alternative medicine to treat diabetes. Yeah, and in the research gaps, we not really have a metabolic profile. This is a preliminary research, but the point I'm trying to share here is there is a big room for us to look into this plant, and in Malaysia, in MSU particularly, we do have labs and we do have MSU Pharma. MSU Pharma is our own company which is focused for the production and distribution. So hopefully we can do the research here, we get the clinical data, and we do have a ready manufacturer and ready distributor to make that product is available in market. Okay. All right, next. This is our objective. We looking to anti-diabetic activities of this plant by using a rat. The rat is we induce by streptozotocin, which is that molecule drug to make them diabetic rats. So after that, we will elucidate the metabolic pathway, and hopefully we can see the outcome through the LCS MECTOF, and from that we will see the difference of all the metabolic we are aim for. Okay, this is a plan we are using. Is starting by the methodology, of course, the instruction. After that, we do the make the rat become diabetic by using STZAC, and then after that, we elucidations and we do the try to look into the mechanism of actions of the crystallise versitiolinase of extractions. Okay. Common practice is very simple method. We collect the plant leaf and in the extraction, we dry it by rotary apparatus, and we find out which the best dose to have the impact, and then we analyze the metabolics by using the LCMS QTOF for the metabolomic profile. Okay. We grouping a few rats. All the rats we have a control, the one's control drug, and a few rats we give 50 milligrams per body weight for the one group. The second group is 250 milligrams of instructions, and third group is 500 milligrams per kg body weight. And after that, we also use that metformin to look into the differences. And after we do the collection of serums, we run the LCMS and we multivariate data and we find it. And this is a result. We look at it. The result shows that the body weight of groups is increased because is stated is saying that the CTZ is effective, make them become diabetes, and after that the body weight is reduced, is proof that they have been infected by diabetic patients, and we treat all the diabetics rat by extraction of plant, and we find out the the significant difference of data. The fasting blood glucose before and after, there is a significant data and show there is the activities of plant, extraction of plant. There is data and shows that there is a significance of serum glucose level. Is that we mean that the plant have activities, and from that we also focus on the potential biomarkers to study. There is 9 biomarkers to study. There is shows the effect, the differences of the biomarkers, and I hope we can do the further study of these biomarkers. To conclude the analysis, we focus on the purine metabolism as very significant changes. Others that not really have significant changes. So furin, taurine, and scorbut is there is a very significant of changes if you compare the control and the group of rat which is a treat. In this group, we focusing on the rat who are receiving 500 milligram per body weight. This dose have a significant result compared with the other dose. So we conclude that 500 milligram body weight of instruction have a strong activity compared with the others strength. So from this study, we can conclude the certain metabolite have changes, and we can go further studies to look into the relationships of the diabetes and the treatment. And the dose, the best dose is a 500 milligram per body weight. Is the best dose for that group of rat. Okay, so the conclusion, in vivo tests demonstrate that 500 milligram per kg body weight, the extract reduced blood glucose level, just what I mentioned just now. And the metabolic reveal biomarkers associated with diabetes-related pathway and potential mechanism of actions. And that plant, Citivius, shows promise as a natural antibiotic treatment. So I'm here to promote the medical doctors, pharmacologists, and scientists. Maybe can work with MSU. We can do the research together to finding the isolation, the quantification, and the potential chemical markers, and genomic and proteomics research should be conducted to explore the mechanism action, and also the further research should aim to develop a standardized of formulation for optimizing extraction. So Dr. Nizam asked me to be here to promote this project because we have a complete, facilities. We have a lab, we have a manufacturer, we have a distributor. So why not we make it our finding in the lab at the end become a product and can be beneficial to the public to treat diabetes rather than we are focused on that. So I would like to throw a few, maybe you all realize a few things in the year 80s or 90s. Do you come across there is a common practice in orthopedic doctors to treat the wound by honey? We call it honey dressing. Anyone have experience before using the honey dressing? You do, Dr. Karina. Here as well. Still practice?
So I think with the patients I found, it's a common knowledge here for people, especially with the burn trauma. They usually think that honey is the first option. So it is very common as well here for us to find a patient who already treat themselves with honey as well.
Okay, good. So that is kind of phenomenon we love to repeat in Malaysia. In Malaysia, gangrene dressings also using the honey dressings. It's very effective. Maybe all of us come across or been used ginkgo biloba, isn't it? Ginkgo biloba. Yeah, very famous for the blood circulation and increase the memory. Also, it's coming from the herbs. It's a herb and become allopathy product and become widely used in Malaysia. So we are in Nusantara, Indonesia, Malaysia, Thailand, Philippines. We are in the same region. We have a lot of potential herbs can become modern medicine as well. So the message here, I would like to invite all of us here. Maybe we can form a group to look into the potential natural product and become a common treatment for the patient widely be used. So I'm really interested with Dr. Farah just now. There is a team, they call it pharmaceutical ingredient and traditional medicine. Well, congratulations, you already go ahead with that approach. And I think it's aligned with MSU. MSU also focus with that. I'm from School of Pharmacy, Dr. Nizam from medical school. We are work together. We are looking for the natural product, and hopefully the natural product will become one of the most treatment to treat particularly for diabetes and other diseases. But currently we only focus for diabetes because the diabetes is the main issue in Malaysia. So I think this is the essence. So with that, I hope I can conclude my presentations. If anything, you would like to email me, and my phone number is here. So on behalf of MSU, we will invite for all of us here to work toward the natural product and try to look into the molecularly of the active ingredient API from the natural product. Thank you very much.
So thank you so much, Prof. Fadli, for your presentation. And I think the first things first, I should congratulate you first on your progress with the study. It is very happy for us as well to hear that your study showing a good significance and a good promising future. I think we will move on to the Q&A session. So is there anyone who would like to ask question? Okay. Sir, if you have a question, you can come forward and deliver the question directly to the presenter.
All right, thank you so much. Let me introduce myself. My name is Daniel. Actually, I work at Bioinformatics Research Institute of Indonesia, or we know that in Bio Indonesia. And then I would like to ask to our esteemed keynote speakers, invited speakers, from bioinformatics perspective. First of all, I would like to ask about the malaria. And then I would like to ask about the malaria research from bioinformatics perspective. I see from your presentation that BRIN already use some bioinformatic tools such as whole genome sequencing, and then phylogenetic tree, and then I see that metagenomic, and maybe vaccine design in your research about the malaria. And then is there any groundbreaking or another innovation that BRIN still develops until now to overcome the malaria from bioinformatics perspective? Maybe there is some bioinformatic tools that already used in the another country, but Indonesia is still in development. And then to Professor Mafadli, I also would like to ask you about the bioinformatics perspective, especially for the pharmacological. And then I did not see any I did not see from your presentation about the in silico for drug discovery as part of your research. Did you also do the in silico drug discovery or no as part of your research? Maybe that's all for me. Thank you so much.
So thank you, sir, for the questions. Is the questions clear enough? Yes. Okay. So maybe we will answer the first question for, about malaria first. So to Dr. Farah.
Yeah, thank you for the question. Yeah, actually bioinformatics is now the tools to try and achieve informations about the genetics of any pathogens so that it can help us in producing more effective vaccines, and also in trying to determine the rapidness, the progress of like drug resistance and also insecticide resistance. So in the Aikman Research Center, we in malaria we already have two parasites that we developed quite a lot of bioinformatic informations, the falciparum and Vivax malaria, and we collaborate closely with the Menzies Research Institute in Australia and Wellcome Trust in British. Yes, and actually there is quite a lot of reference publications that we can look at. Thank you.
All right. To answer the question, what I understand is pharmacological activity in our labs. We also involve the bioinformatics as well. We start with the molecular synthesis, we do the molecular modeling, but now in MSU we start doing the 3D printing of the molecular and so on. So we using the how to say apps or model for formulations to get the molecular from the natural plant. So the API, active pharmaceutical ingredient, we do the isolations, and now we pass to the team related to the bioinformatics to try to do the modeling of the molecules, including the small molecule. This is what we are doing. But these things is not under School of Pharmacy. We pass to the Faculty of Health Sciences, and they are more focusing on bioinformatics. So that is why we in MSU, we are very collaborative between medical school, pharmacy school, and also the health sciences. We are work together with that. So related to the pharmacological activity is not only focused on synthesis the molecule, we also involve in some sorts like bio BA, BE, and also some sorts like preclinical data labs. And we also work with the India research organizations to look into the bioequivalence and bioavailability. We are also using their expertise to help us to make sure that our finding is more accurate and more relevant. So I hope I can answer your questions.
So thank you, Prof. Fadli. Is it answering your question? Okay, thank you so much. So do we have any other questions from the floor? Okay, please, Ibu Joanne, come forward to the microphone in the floor. Thank you.
Okay. Thank you for the opportunity. My question I'm addressed to Dr. Farah. My question is, can human genetic diversity, including factors such as ethnicity and race, influence the response to mechanism of action anti-malaria drugs targeting the parasite as agent and infectious? Thank you.
Thank you so much, Ibu Joanne. Is the question clear enough?
Yeah, thank you for the question. So yeah, genetic diversity, like Indonesian, the ethnicity and race, it also has some influence in drug metabolism. The one that that is widely known already is the deficiency of G6PD, which is an enzyme that occurs in the metabolism of drugs. So other than anti-malarial drugs, G6PD also involves in the hypertensive drugs, and it's quite a lot of number of drugs. But like other than G6PD, there is also ethnicity that in some areas in Indonesia, there is differences in the gene that produce hemoglobins. So we call it the thalassemia, which has been, there are two types, the alpha thalassemia and beta thalassemia. And actually, the person who has those differences, like that ethnicity difference, they can overcome, they don't tend to get severe malaria. So because their blood, the normal bloods, because the thalassemic blood, when it's infected with malaria, it destroys itself more frequently. So the malaria infected blood is discarded, and when they put a drug, it's more effective because there is only a little amount of infected red cells to overcome. That's another one. So yeah, there is quite a lot of ethnicity that we can also approach, like Southeast Asian ovalocytosis, and like in Africa, the sickle cell anemia also are more resistant to malaria infection. Thank you.
Thank you so much, Dr. Farah. It is very interesting as well to hear that there's a silver lining in everything, I guess. So before we proceed to another question, maybe I have another question personally for Dr. Farah, if I may. So my question would be like, for the patients with the false negative malaria detections, do you have any recommendation on how clinician could proceed with that condition? Do we can exclude them, or is there any recommendation we can repeat the test again?
Yeah, that is it's actually a global challenge for malaria detection, because with the rapid diagnostic test, it is almost the main source for malaria detection in remote areas, because with the golden identifications, which is the microscopy, you need to have skills in identifying the microscopic result, and you need some sources to produce the good stained slides, malaria slides. So with the false negative, fortunately in Indonesia we haven't found any mutation yet, so we don't very much worried, but we still need to do surveillance in trying to detect the earliest come. Although in RDT false negative also happen in some cases when the RDT is stored not properly, so the antigen antibodies reactions doesn't work very well. So better to, I think if we get a negative result from the RDT, it's better to repeat in some hours, because sometimes it's false negative because in falciparum the parasite itself ruptured periodically, and when it's ruptured, it doesn't give a correct answer in diagnostic. So after a few hours, there are more that infects more blood, and hopefully the detection can be more precise then.
Thank you, Dr. Farah. I think we as a medical doctor should pay attention to her answer as well, because it is very interesting in our medical services. So I think we will have one last question from the, okay. Sir, can you please proceed to the mic?
Okay, Bismillah. Assalamualaikum warahmatullah. My question going to Prof. Fadli. First, I'm also a pharmacist, so I'm interested about your presentation before. We know that to produce one drug have a long process, say that in vitro, in vivo, and clinical trial. And how about the next for your clinical trial from your research that you have presentation before? And the second one of my questions is Indonesia also have many research about herb medicine, but we lack in their research about their toxicity. We know that the effect of drug or substance or chemical substance have effect to our body, not only the effectiveness but the toxicity. And as we see that our like in Indonesia is less or little research about the toxicity. Yeah, that's it. Thank you.
So the question is about the toxicity of the drug, correct? Okay. So, Prof. Fadli?
Toxicity. Question is talking about toxicity of the drug, is it? Okay. Yeah, there is the thing when we're talking about the clinical trial, definitely involve the toxicity. We cannot run away from to evaluate the drugs before the market. We have to look at toxicity as well. That is why clinical trial, as you know, there is a phase 1, phase 2, phase 3, and phase 4. All these things to look into the safety and efficacy. So the first part, we have to draw the line, the therapeutic window, looking to the therapeutics window and which line can develop toxicity. So that toxicity, one of the area I think is very, very important for all of us to look at it. And also sometimes we have to look into the toxicity related of drug how to say, interactions. Yeah, it's not only for we look into the toxicity of the molecule or drug alone, we look into the interaction as well. The study of interaction from drug A and drug B and develop the toxicity is not really focused in our pharmaceutical line yet. So we always focus on the drug. We have to make sure the drug is past the toxicity, past the efficacy, past safety, then manage register, and we put it in the market. That is what we are doing now. I'm really interested with what you highlight is about toxicity. It's across in my mind that we should include the toxicity related of drug-drug interactions. That is the thing one of the area we have to look at it. And furthermore, currently in Malaysia, particularly in Malaysia, our patients go to see a doctor and the doctors prescribe the modern medications, right? But when at back, they meet their friends, end up they go for traditional medicine or non-registered product. So from that, actually, possibility to develop the drug-drug interaction, which is lead to the toxicity, is there. I dare not to say it's a big or whatever, but I do believe it's there, drug-drug interaction toxicity. So it's a good if you can take part in this area to go for this further study, to look into drug-drug interaction is really, really good. From what I can see is we can get one group of patients and we do the study what kind of food or medicine they always take together. And from that, we look into the metabolic approach, toxicity approach, and as well look at the body system and so on. So hopefully we can conclude there is a drug-drug interactions. So like you mentioned, if you notice some tetracycline, clindamycin, there is a cannot take together with the milk and so on, right? So this thing is not really been make public aware. Take a medicine, they can take milk, but actually this one of thing can develop the toxicity. It's good, thank you very much. You highlight the very important area, very important discipline for us to explore, for us to make awareness to the public. the medication and the food, medication to the medications, medication with the way our lifestyle also actually can lead to the toxicity. Thank you very much. Hopefully it can answer your question.
Thank you so much, Prof. Fadli. I think I can get a sense that everyone is very interested in your research, and we are looking forward for your clinical, maybe the next one. Looking forward to your study. So do we have more questions? Okay, so do we still have time, committee? Okay, so please, Ibu Melda, to proceed with the question.
I would like to ask Professor Fadli. Prof, I believe that Indonesia has similar thing with Malaysia in terms of traditional medicine, yeah, especially in utilization of herbal medicine. I just wonder, sir, in your opinion, what do you think that evaluating the anti-diabetic activity of Escherichia coli live extract in vivo using rat models is effective for the development this extract as an anti-diabetic drug in the future? And how big is the chance? Yeah, is that my question clear?
So I think the question is about
prospect in the future.
Yep, the prospect of your research. So it's
Yeah.
very interesting that you have success in vivo steps. So what is the next step? And do you think it will be also effective in a clinical phase?
Yeah.
Is it okay?
Yeah. How big the potential or the chance? Yeah.
Yep, potential drug in the future.
Natural product. Yeah, as potential of natural product or nutraceutical or herbal product related, actually in my studies right now, in a pharmacy, we not only focus on natural product, we do studies about the low molecular weight of active ingredient as well, of related to the modern medicine. We do that, but related to here, I'm talking about herbal, been given a topics. So there is a one part of active research in MSU. But what I can say is the future, particularly in Malaysia, what I can assure it, is a very big demand. People try to run away using chemical medicines, especially talking about steroid. I'm talking about Malaysia. Malaysian people, even though they are orang kampung, not really, but when they heard about steroid, they are very scared. And when they said this is hospital medicine, they tend to do that, okay, I have to take. But at the same time, they are always search the natural product. They're keen to looking for the natural product. In pharmacy, we are studying, we're talking about the compliance, patient compliance. And what we notice actually, patients, some sort like they have been, they say, some sort like they no choice, and they have noticed there is no solution. For diabetes, for example, they have to take the medication until they die. Hypertension, still there. Whatever medicine they take, still there, just a control. So they try to find the alternative. Hopefully, they can get the medication which can cure the diabetes, we can cure the hypertension, which is currently we saying that impossible. But the public in Malaysia, particularly, they are try their luck. Hopefully, with that product can help them solve the issue. Due to that phenomenon, the natural product become opportunity for the natural product to make it popular and everybody use to support the modern medicine in the hospital. That is the phenomenon in our society in Malaysia. So to answer to that, with that phenomenon, natural product become very, very popular and very high demand in Malaysia, particularly in Malaysia. So that's why our School of Pharmacy think, why not we study the natural product with clinical data support to make sure that whatever natural product in market, there is the evidence base so that the public will not waste their money to take the natural product. Furthermore, we don't want that natural product have a toxicity effect. That is why our in MSU, School of Pharmacy, keen to proceed with the natural product research, and we try to explore into the clinical trial for the natural product. So to answer your question it is a big opportunity and big demand in Malaysia, and also the big opportunity for the pharmacists and scientists and medical doctors to explore in the natural product research, and at the end we can come out with a very good product, safe product, and very good efficacy to help our patients. Thank you very much.
Okay, thank you so much, Prof. I think we all very happy and we are praying for your success in your study. So we are looking forward to the study. And I think that was the last question for this session. So thank you so much for our respected guests and all the participants. And that brings us to the end of the session. And we will moving on to presenting the token of appreciation. We will invite our beloved Dean, Dr. Berta Jenque, neurologist, to come forward to present the token of appreciation. Dr. Farah, please come forward, and our beloved Dean will present to you
Once again, thank you to all our distinguished speakers for insightful and thought-provoking presentations about malaria and role of herbal medicine and archipelago. And to our moderator for guiding today's session with expertise and grace. You may return to your seats.
Ladies and gentlemen, for your information, the parallel sessions are currently taking place from 11:15 to 12:45 local time across 2 designated rooms on the 6th floor, namely Santika 2 and Santika 5. If you would like to join the oral presentation, you are welcome to head directly to the 6th floor. And after that, at 12:45, we will proceed to lunch break until 2 p.m. After lunch, there will be a super fun session with lots of prizes, which is door prizes giveaway. And followed by that, we will do the awarding ceremony and the official closing. Please make sure to return on time and see you after the break. Thank you.
Menjadi hebat itu tak hanya berwawasan luas, tetapi juga memberi makna. Halo semuanya, selamat datang di Ambon City of Music. Inilah Universitas Patimura atau yang biasa disebut Unpati. Dan kami adalah mahasiswa dari salah satu fakultas unggulan yang ada di Unpati, Fakultas Kedokteran.
Fakultas Kedokteran Universitas Patimura didirikan pada tahun 2008 dengan muatan lokal dokter pulau sebagai salah satu keunggulan yang dimilikinya. Dokter lulusan Fakultas Kedokteran Universitas Patimura diharapkan dapat menjadi tenaga medis yang profesional di lingkungan gugus pulau, mengingat sebagian besar wilayah Maluku adalah perairan.
Sarana dan prasarana belajar menjadi salah satu faktor yang penting, dan inilah yang terus dibuktikan oleh Universitas Patimura. Di sini, kamu ditempa menjadi dokter yang hebat. Di sini, tak hanya menjadi dokter yang berkualitas, tetapi menjadi seorang dokter kepulauan.
Dalam proses pembelajarannya, mahasiswa Fakultas Kedokteran diwajibkan mengikuti 4 blok pembelajaran, dokter pulau 1 sampai 4.
Di sini, kalian tidak cuma dapat ilmu, tapi kalian akan didorong untuk menjadi lulusan terbaik dan berguna bagi banyak orang.
Dalam menunjang perkuliahan, mahasiswa Fakultas Kedokteran Unpati difasilitasi oleh lab-lab yang mumpuni. Salah satunya adalah lab histologi.
Pada blok dokter pulau 1, mahasiswa belajar sosiologi, antropologi, geografi, dan klimatologi daerah kepulauan. Pada blok dokter pulau 2, mahasiswa belajar mengenai kesehatan maritim, termasuk di dalam kapal. Pada blok dokter pulau 3, mahasiswa belajar mengenai kesehatan di dalam laut. Dan pada dokter pulau 4, mahasiswa belajar tentang penelitian kesehatan yang berhubungan dengan wilayah kepulauan dan sumber daya yang dimilikinya. Ketika menjalani tahap kepaniteraan klinik, dokter muda dari Fakultas Kedokteran Universitas Patimura juga diwajibkan menjalani rotasi dokter pulau untuk meningkatkan kemampuan mereka melalui berbagai praktik penanganan masalah kesehatan masyarakat wilayah kepulauan. Kegiatan ekstrakurikuler Diving Club Fakultas Kedokteran Universitas Patimura juga dibentuk untuk mengasah kemampuan dan keterampilan mahasiswa dan memperkenalkan kekayaan bawah laut dan ekosistemnya kepada mahasiswa Fakultas Kedokteran Universitas Patimura.
lulusan Fakultas Kedokteran Universitas Patimura memiliki pengetahuan dan keterampilan yang baik tentang masalah kesehatan di wilayah pesisir, lingkungan laut serta kapal sehingga mampu memberikan pelayanan kesehatan yang optimal bagi masyarakat dan lingkungan kepulauan.
Sukses berawal dari keberanian bermimpi dan melangkah untuk menjadi seorang dokter yang terbaik.
tergambar cerita tentang kita, terpisah jarak dan waktu. Ini ku ungkapkan rindu lewat kata indah, tak cukup untuk dirimu, sebab kau terlalu indah. Dari sekedar kata, dunia berhenti sejenak menikmati indahmu. Dan apabila tak bersamamu, ku pastikan ku jalani dunia tak seindah kemarin. Sederhana tertawamu sudah cukup lengkapi sempurnanya hidup bersamamu. Jika hariku lalui tanpa hawamu, percuma senyumku dengan dia. Dan apabila tak bersamamu, ku pastikan ku jalani dunia tak seindah kemarin. Sederhana tertawamu sudah cukup lengkapi sempurnanya hidup bersamamu. Apabila tak bersamamu, ku pastikan ku jalani dunia tak seindah kemarin. Sederhana tertawamu sudah cukup lengkapi sempurnanya hidup bersamamu. Sebab kau terlalu indah dari sekedar kata, dunia berhenti sejenak menikmati indahmu.
Mata pernah melihat, telinga pernah mendengar, badan pernah merasa, terekam jelas, seakan terjadi baru saja. Siapakah yang salah? Siapa yang tanggung jawab?
Perjalanan membawamu bertemu denganku, ku bertemu kamu. Sepertimu yang ku cari, konon aku juga seperti yang kau cari. Ku kira kita asam dan garam, dan kita bertemu di belanga. Kisah yang ternyata tak seindah itu. Ku kira kita akan bersama, begitu banyak yang sama, latarmu dan latarku. Ku kira takkan ada kendala, kukira ini kan mudah kalau aku jadi kita. Kasih sayangmu membekas, redam kini sudah pijar istimewa. Entah apa maksud dunia tentang ujung cerita kita tak bersama. Semoga rindu ini menghilang, konon katanya waktu sembuhkan. Akan adakah lagi yang sepertimu? Ku kira kita akan bersama, begitu banyak yang sama, latarmu dan latarku. Ku kira takkan ada kendala, kukira ini kan mudah kalau ku jadi kita. Kau melanjutkan perjalananmu, ku melanjutkan perjalananku. Ku kira kita akan bersama, begitu banyak yang sama, latarmu dan latarku. Ku kira takkan ada kendala, kukira ini kan mudah kalau aku jadi kita. Kukira kita akan bersama. Hati-hati di jalan. Cinta tak lagi sama sebanyak, ku hanya bisa lupakan. Takkan pernah ada sebanyak, takkan pernah sama. Ku hanya ingin
meskipun terancam surut. Lalu kakimu melangkah ke rumahku, setengah melirik mencoba rayu. Apa yang kau inginkan dari senyumku ya Tuhan? Gemar sekali kau lukiskan bintang untukku. Sungguh lihai tanganmu menata kembali hati yang hampir mati. Kan ku letakkan hangat di tengah dekat kita. Jangan biarkan ku pulang ke rumah yang bukan engkau. Bicarakan tentang seisi dunia, perlahan mendekat, bisikan cinta membuatku terlena ke dalam pesona sukma yang begitu indah. Apa yang kau inginkan dari senyumku ya Tuhan? Oh, gemar sekali kau lukiskan bintang untukku. Sungguh lihai tanganmu menata kembali hati yang hampir mati. Kan ku letakkan hangat di tengah dekat kita. Sungguh manis lawang isi, ibu bapak punyalah dia. Waktu beta kecil selalu dibawa
beta sakit, hati beta terasa tenang, duduk murung serta tangis, air mata kepala. Sayanglah apa tempo balela kembali ingat tanah tumpah darah lagi ibu, bapa dan saudara. jua rasa satu mau dua. Rasa satu mau dua.
Selamat siang Bapak Ibu hadirin yang kami hormati. Kami mengundang Bapak Ibu hadirin sekalian yang masih berada di luar ballroom untuk dapat mengambil tempat di dalam ballroom karena dalam beberapa menit ke depan acara akan segera dilanjutkan. Terima kasih. Selamat siang Bapak Ibu tamu undangan yang kami hormati. Kami infokan sekali lagi bagi Bapak Ibu tamu undangan yang masih berada di luar ruangan untuk mengambil tempat di dalam ballroom karena dalam beberapa menit ke depan acara akan segera dilanjutkan. Terima kasih.
Good afternoon, ladies and gentlemen, and welcome back to the Second International Conference on Health and Medicine 2025. It's time for something a little different. Let's take a short break from science and all other sophisticated matters and dive into something exciting.
Very true, I agree. We really need something exciting, right?
Yes, we do.
But what is excitement?
Okay, can anyone guess maybe from the left side and the right side what excitement we're talking about? Any guesses? Ada yang bisa menebak kira-kira yang menyenangkan ini sesinya sesi apa? Let me give a hint. There's a lot of prizes. So what is it? It's door prize time. We want you guys to be more excited for this part, okay? You can see to our, this is my left side, we have 9 presents and 9 prizes for you to bring home, okay?
We have 5 grand prizes through the spin wheel for the second game. And for the first game, we have 4 fun prizes. A game called Find and Run.
Okay, let me make it clear. So we have 5 grand prizes through spin the wheels. So you're gonna have to listen to the rules very carefully for that. And then we have 4 fine prizes for a game called Find and Run. Okay, we have rules for that and we really appreciate if you can participate in this one. Okay, so let's start with our first segment. Is the IT ready for this? Yes, you guys ready? Okay. Listen up very carefully for the rules. So we will spin the wheels 5 times. Oh, sorry, my bad. We're going to the interactive part of the game, which is find and run. Okay? Find and run. Listen very carefully to the rules. We will announce an item, for example.
Like maybe diamond, tissue, battery, or something like that?
It's a very random things that you can find maybe in your bag or in your pockets or anything. So be prepared. And then if you have it, you're going to want to hold it up like this. I have it here. But that doesn't mean you're going to win the game. Because you need to run to the stage. Okay? You're going to have to run to the stage and hand it over to both of us. Okay? It's going to be very random. It's nothing close to science or anything. It's just purely for fun. Okay? Are we ready? Okay. Remember, the first person that reach, let's go, come down here. Okay. The first person to reach here and brings the correct item will win this game. But you can only win once for this game. Only one, okay? Only once. You can't be another winner for another game. Okay? Are we ready to run? Okay. The first item that we want you guys to hand it over to us is
a boarding pass.
A boarding pass. A ticket plane. Anyone? Ticket plane? Come on, come on, come on. Run, come on. No, it should be physical. Okay. Well done, Ibu. Thank you. Okay. You can return to your seat. Second one. Okay? Second one. We really want you guys to participate on this, okay? Any printed photos. Any printed photos. Any printed photos. Come on, if you have it, hold it up and run. Okay. We have
the
one winner.
winners.
Okay. What photo is this, doctor? What photo is it? Also, he holds up a formal red background photos. Can you show it to everyone, doctor? Okay. There's a misconception right there, but all right. Okay. Next up. This is our third prize, okay? Come on. We only have 4 for this one, so this is second to last. Okay. Open your bags, be ready, because this is very easy, and everyone might have it. We don't know.
The third item we want is
red wallet. Any red wallet. Red wallet. Red wallet. Come on, come on. Red wallet. Run. Okay, we have one red wallet. Thank you, Dr. Eddie. Can you wave it to everyone?
Red wallet, everyone.
Thank you. And last. One last game for this one. It come in handy, and we really need it during COVID time, and I think we need it until today. So what is it? Hand sanitizer. Hand sanitizer. Anyone? A hand sanitizer. Come on, Brett. Come on. Okay. Thank you very much, Dr. Hilda. Okay. The dean has it, you know. The dean already have it there, but she didn't run, so.
I'm so sorry.
I'm sorry, Dean. You have to run for this game. I'm sorry. Okay, so please we invite all the 4 winners for this segment to come up and receive your prize. Okay, all the 4 winners. We're missing one. Ibu email with the boarding pass? Yes. Okay. Congrats. Give a round of applause to these 4 winners. Wow. The most random thing that I've never thought is the boarding pass, but somehow she has it anyway. Okay. Okay. Because Dr. Eti is also the winner, so we're gonna have to invite another person to present the present. So who should we invite?
Dr. Berta.
The
to come
dean?
forward.
Oh, okay, so she wanted all the speakers to come up and also together to give the prize. Okay. Okay, we need someone to let us know which prize and which. 1 second, 1 second. Okay. Okay. You can choose randomly which one to give. So we have 4 amazing prizes. You can stand for a while here if that's okay to take pictures together. Okay. Oh, okay. And the last goes to Dr. Eti. Okay, we can remain on stage for a while and then we can take pictures. Thank you. Documentation team, please take your stage. All right. Thank you very much. You may return to your seats. Thank you. Okay, we still have another segment, but this is based off luck, okay? Unfortunately, we can't really do anything about it. It's all from the wheel. Okay, we're waiting for the wheel to spin. We're gonna read the rules for this one. So, we will spin the wheel 5 times to generate 5 names, and each spin will select one winner based on your registration number or anything that identify you, okay? If your name appears, please come forward to receive your prize, but this is very important. You must be present in this room. Even a centimeter out of that door, you can't do it, okay? We're gonna have to reshuffle again, all right? So you have to be here, present here, okay? Don't worry, all the committee report, even 2 of us, we can have the chance to win the game, okay? All right, so we have the name here.
Are we ready to spin, everyone?
Okay, we're ready. Let's count together from 3, 2, 1, and then we'll spin. Okay, I don't know how to say it, but let's count together, okay? 3, 2, 1, spin! Okay.
And it goes to...
Oh, who is this?
Philly Wembesi.
Oh my goodness.
Congratulations.
Is she here? Oh, she's here. Okay, congratulations. Don't leave the room or we'll reshuffle again, okay? Okay, second lucky person. The second lucky person, who is it gonna be? Okay, are we ready to spin? Okay, it's generating. Ooh, ooh, whoa! Who is it? Dr. Rita! Okay, she's here. That's great. Congratulations, doctor. The third lucky person. Okay, let's see. Okay. We're gonna have to remove the winners or else you're gonna get the chance to win it. Second
Let's
one.
roll this spin.
Okay, roll. Can you see my name in there? I want to make sure I'm in there too. Okay. Who is this? Dr. Martin Matakupan. Is he here? Oh no! Unfortunately,
We're gonna
have
looking
to
for another
reshuffle.
winner to replace him.
Okay, we reshuffle again. Reshuffle. We're looking for the third person. Okay, let's roll. Let's
see. Who is it going to be? Okay, Indah Fajar Ningsi.
Are you here, Indah?
No.
Okay. We're looking for another
Shuffle
person
again. Let's reshuffle.
The third lucky person.
Third lucky person goes to. Tita Monica! Is she here? She's not here?
Okay, she's here,
Oh, she's
everyone.
here. Okay, that's great. Now on to the fourth person. Okay. Let's see. Who's it gonna be? Shabina. Is she here? Okay, she's here. And the last, unfortunately, the last name. Dr. Etty almost win 2 prizes. Almost is never enough, Doc. Okay. Oh, Dr. Filda, no.
So sorry, Dr. Filda.
The dean stood up and said, no, I'm sorry. We're going to have to reshuffle again. Okay. Let's shuffle last time. One last time. Who is it going to be the lucky one? Oh, I think Dr. Yandi. She's here.
she's here.
I'll invite all the 5 winners to come join the stage.
Okay, Dr. Yati, please come forward.
You can come forward, everyone. The winner, the 5 winners.
Okay, once again, we're inviting the 5
All the
winners
5
to come
winners,
forward.
please take your stage. Please come on up. Dr. Yati, if that's okay to take the stage. Ibu Fili, Kashela, Kadita, Dr. Rita, congratulations. Okay.
A proud bestie.
Let's give one round of applause to the winner. Okay, to hand over the presents, we're going to have Dr. Robin and Dr. Farah to hand over the master prize. Okay. Anyone want to quit? We can reshuffle anytime. Okay. Okay. We're debating which present you guys are going to receive. Okay, just one moment. Okay. We're going by orders. Okay. Wow, insulated jug. That's good for coffee. This is a master prize.
It's a coffee maker, everyone.
Yeah, coffee drip maker. Oh. And last, oh, air fryer. Dr. Yati is receiving air fryer. Wow. Congratulations. I invite all the speakers also to come and join for pictures together. Dr. Richard, if you can come up stage, please. Okay. Big smile, everyone. Big smiles. Okay. Documentation team, 3, 2, 1. Okay. Thank you very much. You may return to your seats. Thank you.
Ladies and gentlemen, as we move forward to the next highlight of today's program, we now arrive at a much anticipated and truly celebratory, no, that's the wrong word, celebratory moment, the awarding ceremony of the Second International Conference on Health and Medicine 2025. This afternoon, we recognize and honor excellence in scientific contribution from our conference participants, those whose work stood out for its impact, clarity, and innovation.
There are two prestigious award categories to be present today. The first is Best Poster Presentation, and the second is Best Oral Presentation. These awards celebrate dedication, research excellence, and the spirit of motivation in addressing health challenges across the archipelagos.
Let us begin with the Best Poster Award. Throughout the conference, our posters have conveyed cutting-edge research and compelling insights in visually impactful ways. Each submission was carefully reviewed by our scientific committee, and today we present the poster that has truly captured both scientific merit and visual storytelling.
And the second runner-up Best Poster goes to
Juan Felix Pangestu.
Disability in leprosy patients, a retrospective study in Indonesia.
Congratulations. Moving on to the first runner-up. The first runner-up goes to Priscilia Mutiara Patisa Kusio.
And finally, the winner of the Best Poster Awards goes to
Muhammad Agung Bari Pratama.
with the title Characteristic of a Patient Receiving Oxygen Therapy at Naval Hospital, Dr. Felix Suharjo, Ambon.
We would like to invite all the three winners to come up on stage. Okay. We're moving on, ladies and gentlemen, to the Best Oral Presentation Award.
We now continue with the Best Oral Presentation Awards. This award recognizes outstanding communications, depth of research, and the ability to inspire meaningful dialogue through spoken presentation. After a careful evaluation by our panel of judges, the award goes to the presenter who's not only demonstrate excellence in the research, but also captivated the audience with clarity and confidence. And The second runner-up, Best Okay, everyone, these all our presenters. Okay, the second runner-up, Best Oral Presentations, goes to Lady Tianti
with the title Evaluating the Effectiveness of 2-Angiogenesis Inhibitor Against Experimental Cerebral Malaria in Mice. Ladies and gentlemen, on to the next winner. The first runner-up best presenter goes to
Saida Rao with the title Why Has God Forsaken Me? Understanding the Spiritual Struggles of Elderly Patients with Tuberculosis. Once again, congratulations. And finally, the winner of the Best Oral Presentation goes to Dr. Zulkarnain Abu Bakar Mars
with the title Measuring Value of Cataract Care with Procedure for National Health Insurance Patient Using Value-Based Healthcare. Would like to invite all the three winners to come up on stage to receive the token. We would like also to invite the winner of the poster to come up on stage as well. We would like to invite the best poster and also the best oral to take place. The best poster could take the right side and the best oral to take the left side. Best oral and oral presentation and best poster to take place on stage. The poster on the right side and the oral presentation to the left side. And then also we would like to invite the best presenter from the oral presentation to take this part right here. The oral presentation, if you're here offline, please do take up the stage. Bapak Ibu hadirin sekalian, para pemenang dari oral presentation telah meninggalkan venue sehingga akan ada perwakilan untuk menerima ketiga hadiah diwakili oleh Dr. Dian Kristi. We ask another two participants to represent the winners to come up on stage. We invite the team to take place to take pictures together with the winners. Foto mese. Thank you very much. You may return to your seats.
Ladies and gentlemen, and distinguished guests, it is hard to believe, but we have now reached the conclusion of the Second International Conference on Health and Medicine 2025. Over the past 2 days, we have shared knowledge, forged connections, and explored collaborative approaches to improve health across the archipelagos.
We would like to express once again our heartfelt gratitude to all speakers, moderators, participants, judges, and sponsors for their support and active participation. Our appreciation also goes to the organizing committee for their incredible effort and commitment behind the scenes to ensure the success of this event.
We hope that the insight and the dialogue through this conference have inspired you, and they pave way the meaningful and lasting collaboration in the fields of health and medicine.
We look forward to welcoming you again at the next International Conference on Health and Medicine. Let us continue to innovate, collaborate, and contribute toward better health outcomes for Indonesia and beyond.
And to deliver the closing speech and to formally mark the conclusion of this conference, we are honored to invite
the Vice Rector for Academic Affairs Universitas Patimura, Professor Dr. Domingus Male, Sarjana Peternakan, Magister of Science, to kindly come forward and deliver the closing remarks.
Good afternoon, ladies and gentlemen. On behalf of Patimura University and also Rector, we would like to thank you very much for particularly the invited speakers for sharing your breakthrough, for your knowledge, and also for your suggestions through the papers or through the presentation you have presented during this occasion. And also for those who involved in this meeting, thank you very much for your participation. We hope that this will not end here, but we have to move forward to set up or establish a further collaboration for the sake of our country and also for the welfare of the people we will serve them. And as we know from the information or sharing from the governor that Maluku has a lot of problem regarding the health and medicines. So it is a good opportunity for us to see more deeply about this situation, and through the second international conference on health and medicine, we could find new solutions to bring our problems and to solve them. And also, we hope also that your stay in Ambon will bring a new insight, and this also will trigger you to come in the next conference. So please just tell your colleagues and your friends that this kind of conference will give more experience, particularly with new environment. And I hope that it's on not only Patimura University and Rural Doctor Network, but also other institutions to come together to set up bigger collaborations, and also from the local government to help these collaborations to be done in the next future. And also I hope that by the end of this moment, we can continue our collaboration even from through the social media, just being contact with one another. Thank you very much once again for all of us who are participating this moment. And on behalf of the Patimura University, I officially close this conference, the second international conference on health and medicine. Thank you very much. Good luck for all of us, and God bless.
Once again, thank you, Professor, for your closing statement. You can back to your seat.
Ladies and gentlemen, with that, we are pleased to declare that the Second International Conference on Health and Medicine 2025 is officially closed.
Wabillahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Shalom. Om Santi 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 Om. Namo Buddhaya. Salam kebajikan. Hotu Mese.
Thank you and see you next time.
It's horizon, it's shining. Seems the daylight knows this is our time now. Where we're going, these dreams we're holding. Oh, and now we know it. All the world is ours to take.
Baik hadirin sekalian, sekarang saya mengundang Bapak Ibu hadirin sekalian untuk dilakukan sesi foto bersama. Untuk itu pertama-tama saya mengundang seluruh tamu yang kami hormati untuk mengambil tempat di stage. Kemudian diikuti dengan seluruh partisipan yang ada di sini untuk mengambil tempat di bagian depan.
Ladies and gentlemen, we'd like to invite you once again for our last photo session together for this event. We'd like to invite all our speakers to take place on stage, and then following all the participants and the committee to take place also at the podium. Kepada Bapak Ibu hadirin sekalian, kepada para tamu undangan terhormat, para pembicara, moderator, dan juga para juri untuk mengambil tempat di bagian atas panggung, kemudian diikuti oleh para panitia dan partisipan yang lain. Dr. Robin, you can also take place. Bapak Ibu hadirin sekalian, para dosen, para peserta, baik itu oral maupun poster juga untuk mengambil tempat di depan. Dr. Eti as Vice Dean, Dr. Eti please take place. Jika memungkinkan, mungkin panitia bisa mengambil tempat juga sebagian. Para panitia pengurus inti mungkin boleh mendampingi para pembicara di atas panggung. Seluruh peserta yang hadir di dalam ruangan ini, baik pendukung acara maupun semuanya yang ada duduk saat ini, mohon mengambil tempat di depan. Kepada para dosen, para kakak koas, kakak dokter, mohon semuanya mengambil tempat di depan. Pak Merian, silakan mengambil tempat di depan.
Makan rujak campur dengan pala, makan di pantai sing ada sisa. Jangan coba.
Bapak Ibu hadirin sekalian, mungkin bisa lebih bergeser, menyamping, menyerong, maka semuanya bisa fit di dalam frame-nya. Bapak Ibu mungkin bisa lebih dekatan, dempetan sedikit, bisa menyamping, boleh juga mengambil tempat di bagian bawah, duduk di bawah. Boleh yang lain di bawah. Sekali lagi kepada semuanya yang ada dalam ruangan ini, mari mengambil bagian untuk melakukan sesi foto bersama. Kepada para tim IT, para tim OSA, boleh mengambil tempat di depan.
Jaga durian.
Kepada tim ASO, boleh mengambil tempat di depan. Tim Pamerian, tim ASO, tim yang lain boleh mengambil tempat di depan.
Kak Fadila.
Kak Fadila boleh mengambil tempat di depan. Mohon arahan untuk dokumentasi, tim dokumentasi apa semua sudah masuk dalam frame? Oke, semuanya sudah fit di frame. Everybody look at the camera and say cheese. Sekali lagi, foto mese, foto mese. 3, 2, 1. Apakah kita membuat video ICHM foto mese? Baik. Ladies and gentlemen, if I say ICHM 2025, everybody say foto mese. Okay?
Bakar ikan di para-para.
ICHM 2025. Foto mese. Thank you very much, everyone. You may return to your seats. Thank you.
Lagu lama penghibur hati.
Recording stop.